Assalamu alaikum wa rahmatullahi ta'ala wa barakatuhu. Welcome everybody to the 7th Gulf Endocrine Review course. We are just about to start our third and last day, and it gives me special pleasure actually to welcome to the center stage the invigilator of the first session about female reproductive disorder, which is going to be conducted by our esteemed colleague, Dr. Huda Izzeddin. Huda is a consultant in diabetes and endocrinology and director of academic affairs in Health Plus Center for Diabetes and Endocrinology in Abu Dhabi, United Arab Emirates. Huda qualified from King Faisal University Hospital in Saudi, and she underwent her training actually in the Imperial College in London. She would present today a session on female reproductive disorder. And with further ado, I would like to welcome Dr. Huda to take over. Dr. Huda, it's all yours.
Thank you so much, Dr. Tariq, and thank you all for being on this platform. I hope you will find this session quite useful. Well, thanks again for your interest in female reproductive endocrinology. I hope you will find this session quite useful. It's a rather shorter session with multiple questions with the common stem or common scenarios. And then we will have some polls to choose from, and then we will have some educational messages to conclude on each of this theme or each scenario. So the topics that will be covered today, the questions will be all around polycystic ovarian syndrome, amenorrhea, hypogonadism in females, adult onset congenital adrenal hyperplasia, menopause, and HRT. Unfortunately, we won't be able to dig into female sexual dysfunction, infertility, and ovulation induction related issues because that will really overlap with OB-GYN. I think with that, we will just jump right away to the first scenario. I would really like you to read thoroughly the stem before answering the question. The first one is a 21-year-old lady who presented with an increasing facial hair, acne, and delayed periods. Her last menstrual period was about 3 months ago, and she has put on 12 kilos over the past 6 months, with a current BMI of 32 kilograms per square meters. Her blood pressure and other system exam was normal. So this is quite a common scenario. I would like you to try answering the first question. Which of the below blood tests will not be required at an initial investigation visit? Would it be the TSH, LH-FSH, testosterone, prolactin, cortisol, or 17-hydroxyprogesterone? Great. So I've got, most of you have answered, Okay, so we've got 1, 2, 3, 4, 5. We've got 6 options, and the majority have answered 17-hydroxyprogesterone. Actually, you would need to do all of these tests at one stage or another. However, looking into the actual stem, telling that the blood pressure, the actual physical examination were normal, then I would actually exclude cortisol at the first instance. Remember that the most common scenario of such a lady, 21, coming with a facial hair, acne, delayed period, is polycystic ovarian syndrome. But we would really, from the first instance, need to exclude adult onset congenital adrenal hyperplasia, as well as hypothyroidism, and so forth. So even if we wanted to make sure and confirm the diagnosis, I would really put cortisol at the very last one, especially if the patient is really asymptomatic with no features of hypercortisolism at this stage. All right, so we'll move on to the second question for the same scenario. So again, the same lady, which of the below investigations is absolutely needed in this case, to reach to a diagnosis of polycystic ovarian syndrome? So now I have a suspicion of PCOS being the most common scenario in this lady. But if I wanted to actually have one absolutely needed test, which would be of those options? Again, I have 6 options. Which of those would be necessary to make a diagnosis of PCOS? LH, FSH more than 2, transabdominal pelvic ultrasound, fasting insulin, anti-Mullerian hormone, day 21 serum progesterone level with suboptimum level, or none of the above. Okay, so I've got 60% of you have answered none of the above, and that is the correct answer. The reason behind that would be the patient is already having clinical symptoms of hyperandrogenemia. So this is actually a clinical hyperandrogenemia, having a facial hair, the acne. She's also having an anovulation by history with delayed period. She definitely has some issues with insulin resistance, but in order to make a diagnosis of PCOS, the clinical scenario is just sufficient. We do not need to have an LH-FSH ratio of more than 2, and that's a common mistake. We do not need to have a transabdominal pelvic ultrasound, and most of the diagnostic criteria stress on a transvaginal ultrasound to see a specific criteria of the ovaries showing the polycysts. Fasting insulin is not really necessary. Anti-Mullerian hormone as a surrogate marker instead of having the transvaginal ultrasound. But again, it's not readily available, and the standardization of the test is cannot be generalized. Day 21 serum progesterone, what am I trying to achieve? Lack of ovulation? Well, she's been having delayed periods clinically over the past 3 months. Well, I think in this question, the right answer is none of the above. And I'll explain it later when we come to the actual messages that I would like you to take home. Now, the last question for this STEM or this scenario is, what would be your first line of management in this lady? Would it be an oral contraceptive pills, the use of anti-androgens, weight management, laser therapy for hirsutism, or metformin? What would be the first line of management? Remember that in PCOS, you would need to use multiple of these agents in parallel. But what would be the first line of management? Okay, so I've got 55% of you said weight management. Yes, but how much weight do you want her to lose in order to restore her ovulation or regular menstrual cycle? We don't know for sure how long and how much weight she would need to reduce. So I would go for an oral contraceptive pills, because oral contraceptive pills per se will actually increase her sex hormone binding globulin, reduce her free testosterone, and actually it will make sure that she will have a regular cycles, not necessarily retain ovulation. That will come maybe at a certain stage of her management. But yes, we would need to start with an oral contraceptive pills if she doesn't have any contraindications. All right. So I think for this first question, I would like to, can I have the actual, yeah, okay. So this is a slide quite that I like, because it just shows the prevalence of the features associated with PCOS. So majority of patients, they present with oligomenorrhea. And so mainly anovulation, followed by clinical hyperandrogenism, like hirsutism or acne. In between, they will have some insulin resistance. Obesity is not necessarily in 100% of the cases. You can see it's like mainly 45% of the cases. And high LH, or a double ratio of a LH to FSH, is only available in about 18 to 20% of the cases. So you don't need to keep that idea in mind that I need to have the double ratio of LH to FSH in order to make up a PCOS. You don't, of course, forget that PCOS can present in young ladies as a primary amenorrhea. Next slide. This is from the Helena Teed latest recommendation from the International Evidence-Based Guideline for the Assessment and Management of PCOS. And she actually goes a stepwise fashion. So if I have an irregular cycles plus a clinical hyperandrogenism, you've got the diagnosis. So this is like our cases. Yes, you would need to exclude that case, but then you would, the cases of hypothyroidism and case of adult onset congenital adrenal hyperplasia. But if you have these two, clinical hyperandrogenism and irregular cycles, then you've got a diagnosis. Step two, if there is no clinical hyperandrogenism, for example, we would test for a biochemical hyperandrogenism, excluding other causes, of course. And the last step would be if you only have a patient with irregular cycles, or if the patient is having hyperandrogenism and nothing wrong with the cycles, then these patients will need to see whether they would have a polycystic ovaries morphology by ultrasound, or we depending on the actual risk factors for PCOS, looking into other factors like the weight and family history of diabetes and stuff like that. Remember that adolescents ultrasound is not indicated in that age group. So try to be careful not to get into that trap. All right. So PCOS in adolescents, even though us as adult endocrinologists, we get patients from age maybe 13 up to age 18 with irregular cycles and the query of PCOS. Sometimes those patients, they go to gynecologists, sometimes they go to the pediatric endocrinologist, but we really need to be aware that 50% of the menstrual cycles are anovulatory in the first 2 years post-menarche. So that's quite normal. The non-pathological acne and the hirsutism are common in peripubertal years. So this is quite common in the ladies having hirsutism at this age group. Remember also that children can develop physiologic insulin resistance during puberty because of a lot of that steroidogenesis that is kicking in. The lack of standardization of androgen levels by BMI and the pubertal stage, that can actually make us analyze what would be the normal androgen level for that age group. We know that 25% of adolescent girls have multifollicular ovaries. So not necessarily is viewed as polycystic ovaries, but they will definitely be looking at like follicles. And the anti-Mullerian hormone should not be used in adolescents. Having these messages in mind will actually prompt us to the second question that we'd like to get to see. Let me just. So, having said what I told you about is that let's look into the second case, and that you will get to the right answer right away. So this is a 15-year-old girl brought by her mother because of irregular periods, and she also has an anxiety issues. She attained the menarche at the age of 13. So from the time of menarche until the age of 15, there's only 2 years. So she is lean and has no hirsutism. Her BMI is 20 and system examination was normal. So which of the following is likely to exclude the diagnosis of PCOS? Is it the absence of hirsutism? Is it normal BMI or a normal PCOS morphology by ultrasound, normal free testosterone, or normal LH and FSH, but mildly elevated prolactin. You should all get this answered correctly. Good. So I've got 43% answered a normal free testosterone. Yes. So in this case, let me just go through the rest. Yes. So in this case, actually, this is part of the pubertal irregular cycles in this age group. Let me just close this. Yeah. So so the right answer is if I have a normal free testosterone, then that will exclude a biochemical hyperandrogenism. So if she doesn't have hirsutism, so that is actually the clinical. She doesn't have a clinical hyperandrogenism, and if she doesn't have a biochemical hyperandrogenism, then like 50% of the case is lost. She does not have that. Looking into the age group and having irregular periods, that could be just a normal physiological changes in that age group. And the LH and FSH, as I explained before, is not necessarily to be a double ratio. So the second question of that scenario, what is the best management strategy at this phase? Is it reassurance, as this could be a normal phase in pubertal development? Would you start combined oral contraceptive pills? Would you induce withdrawal bleeding if her LMP is more than 90 days? Or would you try inositol, Ovacure, whatever of those? Or would you do reassurance, but at the same time, I would induce the withdrawal bleeding if her last menstrual period is more than 90 days? What would be your answer for this question? Okay, so yeah, you would reassure her, but at the same time, you would induce a withdrawal bleeding if her last menstrual period exceeded 3 months in order to avoid thickening of the endometrium. All right, so I'll just get into the next. I've explained this, and the algorithm of diagnosing stress the fact that PCOS in adolescents is really a very specific period in age where things are not yet steady, and the maturation of the hypothalamic pituitary ovarian axis is not yet complete. Because of that, we need to be really clear about what do we mean by irregular menstrual cycle? What do we mean by oligomenorrhea? So what is normal and what is abnormal? So if you see that ladies who are having their first year post-menarche and having any irregularity, that is normal. Again, between 1 to 3 years post-menarche, we would expect that having either a short cycle or a prolonged cycle in between. But anything after 3 years post-menarche to perimenopausal, if I have anything more than 35 years, then I would call that oligomenorrhea. So a lady should not have less than 8 cycles per year. And even within the first year post-menarche, one should not have more than 90 days without any cycle at any stage in her reproductive phase. And that's what we call a secondary amenorrhea. Remember that anovulation does not mean oligomenorrhea. Anovulation is just a failure to release the oocyte from the ovaries, and it can happen actually in 10 to 15% of girls with regular cycles, having a polycystic ovarian syndrome. The test of ovulation, of having progesterone of more than 2.5 nanogram per ml during the mid-luteal phase, yeah, this is how we can test it. But then again, in a patient who's having irregular cycles, how will she count day 21 or day 22? In general, we should not have like three consecutive luteal levels of a total of more than 15. Then that would actually equates to anovulation. And nobody actually tests for ovulation in this age group, 13 to 15, the clinical history is just enough. All right, fine. So let's get into case 3. This is a 17-year-old lady who presented for evaluation of primary amenorrhea now. 3 years ago, she was diagnosed with constitutional delay of puberty. And on examination, she was 1.5 meters high with absent breast development. Pituitary hormones showed a prolactin of 35 nanogram per ml. I'm sure you would know that in this unit, the upper limit is 23. IGF-1 is 119. Thyroid function test, cortisol, ACTH, LH, FSH, cortisol, ACTH were normal, while LH and FSH were prepubertal. When she did a pelvic ultrasound, it also showed the prepubertal adnexal structures. So which of the below tests is needed at this stage? Again, she's a 17-year-old with evaluation of primary amenorrhea, and absent breast development, and she has this wildly elevated prolactin, I would say. So which of the below tests is needed at this stage? Is it pituitary MRI, pelvic MRI, X-ray hands for bone age, perimetry, or we do the GnRH test, or we call it the LHRH test? Which one? Yeah, exactly. I would do a pituitary MRI. She is amenorrheic at age 17 with prepubertal LHFSH adnexal structures are prepubertal. There is something wrong with the development at this stage. So I would really need to know what is happening there upstairs in a pituitary hypothalamic level. So yes, I would do a pituitary MRI. Good. The same patient, we did the pituitary MRI, and a pituitary MRI showed a 6 centimeters tumor compressing the optic chiasma. What is the best next step to confirm the diagnosis? Should we refer to radiation oncology? Should we send the case to neurosurgery? Should we order a serial dilution of prolactin? Should we refer for visual field test? Or let's have a trial of starting cabergoline 0.5 weekly and see what happens. That's nice. None of you wanted her to go to a radiation oncologist. That's excellent. And don't you want to refer to visual field test? Well, yes, but not at this stage. That will not confirm the diagnosis. And some of you said that we wanted to start the cabergoline. Well, not to confirm the diagnosis. We don't do like a test dose of cabergoline and see what happens. And I really wanted to make sure that the patient is really having, with that huge size of pituitary tumor, what is it secreting? Is it secreting prolactin, or is it a non-functioning adenoma with a stalk effect? So I'll talk about this shortly. All right. So this case actually brings up the differences between the hook effect versus a macroprolactin molecule. So in a busy clinic, sometimes we overlook the amount of the prolactin level that we are seeing. Does it really make sense does it go in parallel with the clinical scenario, or does it actually looks odd? So in this patient, the level of the prolactin is slightly elevated, and it's a bit odd for that huge size with the pressure on the optic chiasma. So in this case, that would be the hook effect. But let me read the differences between a hook effect and a macroprolactin. A macroprolactin is an immunoglobulin conjugated form of prolactin, which is cleared slowly from the body and can produce prolonged positive results in the lab. So a very high level of prolactin, however, it's biologically inactive. And it will be inappropriately elevated in a patient who might be asymptomatic and with irregular cycles, for example. And this can be tested by treating the sample with polyethylene glycol and look into the precipitation percentage. Anything more than 60% will actually be suggestive of the presence of macroprolactin. While the hook effect of prolactin is an assay artifact leading to an underreporting of an extremely high prolactin levels. So when the amount of prolactin present in the sample is too high sometimes, and it is really exceeding the capacity of the binding of the antibodies being used, then the test result may indicate a falsely low level of the prolactin, like in this case. And therefore, we would need to do a serial dilution of the sample that will actually reveal the true value of a very high prolactin. Good. We'll move on to the fourth case, and this is a 16-year-old girl who presented with primary amenorrhea and poor breast development. Now, the mother indicated that they have two other girls in the family who got their first period at age 18. And on examination, her breasts were Tanner 1 to 2 with normal growth curves. Her height was 156, weight 49, and a normal BMI. So the following may be included in the differential diagnosis of this case, except, and I have placed the hormonal profile of this girl who presented with primary amenorrhea and poor breast development. Could it be a congenital GnRH? So we're looking at the differential diagnoses of this girl, except one option that really doesn't make sense. I'm trying to lead you to the answer, but anyway. So congenital GnRH deficiency or a constitutional delay in puberty, a functional hypothalamic hypogonadism, or a premature ovarian insufficiency, or could it be a brain tumor and we would need to do a pituitary MRI? What would you say? Remember in the exam, sometimes the examiner will throw some red herrings here and there, trying to confuse you. So yeah, I would exclude premature ovarian insufficiency because this patient is having hypogonadotropic hypogonadism. And whenever a patient having premature ovarian insufficiency, she will have a hypergonadotropic hypogonadism. And the reason why I put this is because congenital GnRH deficiency is not really seen often, but then there will be a bit of an overlap between the first three, the A, B, and C, the congenital GnRH deficiency with a constitutional delay in puberty or a functional hypothalamic hypogonadism that is actually presenting very early in age. So you've got the right answer, but we will talk about these issues shortly. All right, so the same girl who brought by her mom with a primary amenorrhea, she's 16 with poor breast development. And here are her test results. And one of the following tests will not be helpful in this case. So I would not request it. Is it a thyroid function test, a pituitary MRI, a pelvic ultrasound, LHRH stimulation test, or testing her sense of smell? Which of the following will not be helpful? You wouldn't do it. All right. So none of you said TFT. So what does that mean? So you wouldn't do TFT for this case? Or it wouldn't be helpful at all? Or pituitary MRI wouldn't be helpful? Which one will not be helpful? You will not do it. Yeah, it wouldn't give you much information. Yeah. Okay. So I would do a pelvic ultrasound. I would do a test for the sense of smell because Kalman syndrome can also happen in a subset of females as well. And it's really important to make sure that she's having an intact sense of smell. The LHRH stimulation test will not be helpful because in endocrinology, or at least in the female reproductive endocrinology, the only utilization of LHRH is mainly to exclude precocious puberty. And this patient is far from puberty. I mean, she is primary amenorrheic. So I would not test for the GnRH or the LHRH stimulation. Okay, good, well done. But I would do a pelvic ultrasound just to see if she is having a uterus, or she doesn't have a uterus, or she having an ovaries, or she wouldn't have any ovaries. All right, let's move on. Good. So this is just an algorithm to help you figure out what to do with any patient who's having with primary amenorrhea. And like a definition of a primary amenorrhea is a lack of menses by the age of 13 without breast development, of course 13 or more, or a lack of menses by the age of 15 or more with a breast development. Of course, we would need initial lab tests. We'll make sure that the patient is not pregnant in a specific girls. We would do SH thyroid stimulating hormone. We would do prolactin, the LH-FSH. We would do that, and a pelvic ultrasound is definitely needed, along with a detailed history and examination. We would need to check if the uterus is present or not. That's definitely needed. So if the uterus is absent, then automatically we go to karyotyping and other genetic abnormalities and congenital anomalies. But if the uterus was present, then we look into the FSH, whether it would be a high FSH, and then the patient might have a hypergonadotropic hypogonadism. That's different from our patient. Or if the patient is having a poor breast developing in a way, but we would check the LH and FSH, and if they are low, then we would think of the congenital GnRH deficiency or a constitutional delay of puberty or other functional hypothalamic issues. All right, so you can take a snapshot of this, or you can just check it in up-to-date. It's available last year and this year as well. Good. So let's move on to the fifth case. This is a 25-year-old, little bit, we move on to an older age group, a female who brought by her husband for lethargy and weakness. The patient is a tennis player and was diagnosed with type 1 diabetes at the age of 15 on insulin with good glycemic control. And on examination, she was athletic built with a BMI of 18, and the last menstrual period was 3 months ago, and her 24-hour urine-free cortisol is in the upper limit of normal. So all of the following tests can help with the diagnosis, except we would need to serum prolactin, or we will exclude the serum prolactin, or would we do a beta HCG, or we'll do an LHRH, or a pelvic ultrasound, or the LH-FSH. So what do you think? So she's a tennis player, came with lethargy and weakness. She is diabetic, and her BMI is 18, and they found that her urinary free cortisol is elevated. Is more than the upper limit of the normal. So all of the following tests we would do, except, yeah, so you got it now. All right. So the case number 5, this is the question number 1, we will not need to do the LHRH. Excellent, good. Fine. So we'll go to the same scenario, but the second question. And this time, what is the most likely cause of her high urinary free cortisol? Is it because of her A1C? You know, her A1C is 7.8%. I've given a little bit more of the detail. or the cause of her high urinary free cortisol is adrenal adenoma, or a hypothalamic amenorrhea, or pregnancy-related issues, or lab error. Why do you think the patient might have high urinary free? Would that help you with the diagnosis, for example? Let me know. Yeah, why would a type 1 uncontrolled diabetes would cause high free cortisol in a patient who is having amenorrhea, secondary amenorrhea for the previous 3 months, and she is a tennis player? Well, okay, so the hypothalamic amenorrhea, this is what the patient is having. This patient will be having the hypothalamic amenorrhea, and then we know that there will be some abnormality in the corticotrophin releasing hormone signal in patients with hypothalamic amenorrhea. And that will actually cause a blunted response to CRH, for example, in the ACTH as well as in the cortisol level. And those patients would have a little bit of an elevated cortisol and ACTH, unfortunately. All right, fine. So we'll move on to the other question. Now it is the same lady, but now I'm giving you some blood results. So this lady is having now her LH and FSH, as you can see there, and the estradiol is suppressed, okay? And you correctly identified and knew what could be the diagnosis in the previous question. So what is the best management strategy in this case? Do you think an insulin pump will solve the problem, or stop physical activity, tell her stop her tennis, encourage weight gain? Or should we start her on oral contraceptive pills? Or we can tell her no need to treat, this is a self-limiting condition, go home, come back later in 3 months. Or we can just give her cyclical progesterone. Look at the blood test results and see how would you best manage this case. Okay, so 60% said we will stop physical activity and encourage weight gain. 24 said we'll start oral contraceptive pills. 7% said no need to treat, this is a self-limiting. I wish it is, but it might take like several months or maybe years for the self-limiting condition to for her to have her period get restored. And why would we give cyclical progesterone? What is deficient in this case is estradiol. So the right answer would be to start her on oral contraceptive pills. She would need to reduce her physical activity and maybe put on more weight, but then in a type 1 diabetic, what does that mean? A poorer glycemic control. And then she's a competitive tennis player, and she might lose her job if she does this. So I think this lady, she will definitely need to start some oral contraceptive pills to restore her estrogen supply. All right. Now, given the likely diagnosis in the same girl, this patient is mostly at risk of which of the following? Do you think she's at risk of a malignancy somewhere, stress fracture, adrenal insufficiency, endometrial hyperplasia, or diabetic neuropathy? Easy. Yes, absolutely, stress fracture. So if this patient is kept with low estradiol, of course, with her high impact physical activities, she is at an increased risk of stress fracture. Thank you. Now, I just wanted to go through some acquired causes of hypogonadotropic hypogonadism like this girl. So first, we want to make sure that, of course, there's no cues related to tumors, like prolactinomas, craniopharyngiomas, or metastatic tumors. functional gonadotropin deficiencies, like chronic systemic illnesses, obesity, diabetes itself can cause a functional gonadotropin deficiency. Sickle cell disease has also been reported, type 1 diabetes, like this girl, or if they have an infiltrative disease like hemochromatosis, sarcoid, infections, trauma, vascular ischemia or Sheehan syndrome, pituitary apoplexy, all of these, or some drugs also, all of these can actually cause an acquired causes of hypogonadotropic hypogonadism. So whenever you have a patient who's having irregular cycles and then suddenly she lost it completely with a hypogonadotropic hypogonadism, you will need to go through this list. Then how would we treat? Yes, as you said, that we will need to have lifestyle advice in order to reverse the amenorrhea. We refer to a dietitian. It's going to take some time, maybe a year or two, along with some psychological support for these patients. Eventually, or at a certain stage of the management, you would need to give her some hormone replacement therapy. And the assisted reproduction, if pregnancy is really needed, an IVF might be of use. The experimental use of kisspeptin has been reported with excellent results in a recombinant leptin therapy, and that caused a reversal of this condition. So having said that, I think we have covered such cases with hypogonadotropic hypogonadism. All right. Let us see this girl. So case number 6, she is a 17-year-old girl presented with irregular cycles for a year, and her last menstrual period was 8 weeks ago. Review of the system was positive for fatigue and excess body hair. Her vital signs were normal. BMI is high. Physical examination revealed facial acne and acanthosis nigricans. Which of the following are the best tests for an initial evaluation? So again, I've thrown in some investigations in each of the options. Which one do you think is the best to be checked at an initial evaluation, even if later on you would need to do more tests? Okay, so I don't need to read through each one of them. It's quite clear. You just need to think, why do you need to test each of those options? And what is a priority to check? Yeah, absolutely. So 63% of you chose the right answer, which you would need to check her thyroid function, TSH. You want to make sure that she's not pregnant. And free testosterone is really important in a patient with clinical hyperandrogenism and oligomenorrhea or secondary amenorrhea. Good. The same patient, which of the following statement about diabetes screening is correct? So now we move a little bit from hormones to the metabolic disorders of diabetes. So is there any, if there is no family history of type 2 diabetes, there is no need to screen for diabetes. And if you want to screen for diabetes, would you choose HbA1c as the best test to screen for diabetes mellitus in adolescents with PCOS? Or you would prefer to do OGTT as an optimum test for diabetes screening? Or you would do serial fasting blood sugar or random blood sugar would be sufficient? Or you would do some insulin resistant tests? So this girl, 17, with irregular cycles, with clinical and possibly biochemical hyperandrogenism, acanthosis nigricans, and obesity. Would you screen, and how would you screen for diabetes? Yes, fantastic. So OGTT is the optimum test for diabetes screening in this case, because one would like to do a quicker one, HbA1c, but it is not really recommended in the adolescents. Fine, so we know that glycemic status should be assessed at diagnosis in all adults with adolescents with PCOS, regardless of the BMI. Glycemic status should be reassessed every 1 to 3 years. So initially, an initial visit, then every 1 to 3 years, based on additional individual risk factors for diabetes. And of course, if we're talking about people from the Middle East or having family history of diabetes, then you got it. Almost every 1 to 3 years, you would need to screen for diabetes in patients with PCOS. A 75-gram oral glucose tolerance is the most accurate test to assess glycemic status, regardless of the BMI. So it doesn't matter if the patient is lean, you would still need to do an OGTT. If an OGTT cannot be performed, only then we can do an HbA1c, noting significantly reduce the accuracy. Insulin resistance is a pathophysiological factor. However, clinically available insulin assays are of limited clinical relevance and are not recommended in routine care. This is based on the international evidence-based guidelines for the assessment and management of PCOS in this year. Good. So case number 7, this is a 30-year-old lady who presented with 3 months history of increasing facial hair, thinning of the frontal hairline, hyperpigmentation at the back of the neck. I think you can just see these signs clearly in the photo. Her BMI is 28, her hormonal profile is attached, and which of the following makes PCOS unlikely in this case? So whenever we see such a case, it's like 90% of the cases we really need to think of PCOS. But in this particular case, looking into her clinical scenario, which of the following makes PCOS unlikely? And look at her hormonal profile. So if her BMI is normal, would that exclude PCOS? Whether she has regular cycles, will it exclude PCOS? If she has hyperinsulinemic, premature adrenarche, or her short history of that much of hirsutism. Okay, all right. So yeah, she has like 43% the short history of hirsutism. So a 3 months history of increasing facial hair and the really frontal balding was quite remarkable for her. Let alone the hyperpigmentation, and this cannot happen. Maybe this is due to that insulin resistance that she's been having for some time, but then the short history of that remarkable amount of hirsutism, it just draws your attention to something, especially that her free androgen index is extremely high. So that will actually lead to the next question, which is, if you know that her LMP was 5 months ago, what other tests would you ask for to confirm your diagnosis? Is it a pelvic MRI, 17-hydroxyprogesterone, beta-HCG, total testosterone, or anti-Mullerian hormone? All right. So almost a third chose total testosterone. Others wanted to do pelvic MRI or 17-hydroxyprogesterone, beta-HCG. So we have a bit of a mix here. All right, so let's look at it. So this patient, we agree that in the previous question, she has a short history of hirsutism, remarkable hirsutism in a short period of time, and a remarkably elevated free androgen index. And if you have that much of a free androgen index, you don't need to do a total testosterone. You can repeat the same test again just to make sure that it's not a lab error. But with that level of clinical hyperandrogenism and free androgen index, then that would actually raise the suspicion of having something else that can cause that much of production of testosterone, free androgen index. So I would go for a pelvic MRI to exclude an androgen secreting tumor whether in the adrenal or in the ovary. 17-hydroxyprogesterone, well, I have to say that whenever you have a patient with really extreme hirsutism and insulin resistance, number one would be a PCOS. You need to exclude also adult onset congenital adrenal hyperplasia. And the third would be you should not miss an androgen secreting tumor. You should not miss that. I mean, you can take your time in looking into PCOS or congenital adrenal hyperplasia, but definitely you wouldn't want to miss an androgen secreting tumor in a patient who's having a short duration of remarkable elevation of her frontal baldness and facial hirsutism. One would expect that, however, if that much of testosterone would be there, we will expect that her LH and FSH would be suppressed. But you keep in mind that in such cases, a polycystic ovarian syndrome can coexist with, maybe can coexist with congenital adrenal hyperplasia or with androgen secreting tumor. So all of these things can miss the actual blood test. So pay attention to the actual history. It will lead you to what would be, how would you confirm your diagnosis? A few words about estrogen progesterone during pregnancy. So I've mentioned the beta HCG to be done. However, if in the exam they have given you estrogen or estradiol or serum progesterone, and the patient has been 5 months with oligomenorrhea, you would expect her estrogen to be really, and progesterone to be really sky high if you suspect a pregnancy. So not because that she's might be amenorrheic for 5 years, I don't want to miss pregnancy. Yes, I don't want to miss pregnancy, but I don't want to miss an androgen secreting tumor. And you can look at how they exponentially increase in pregnancy in each trimester, the level of estrogen and progesterone. All right, case 8. This is a 26-year-old lady presented with hirsutism, acne, and irregular periods for the past 10 years. And clinically, her blood pressure was fine. She is hirsute, BMI elevated, acanthosis nigrans. I mean, those girls are quite common. We see a lot of them in clinics. Maybe because I'm a female, I see a lot. And all of these cases are true cases that I have personally seen. So she has this acanthosis nigricans pinkish stria on abdomen. Look at her prolactin, LH, FSH, estradiol, hydroxyprogesterone, 17-hydroxyprogesterone, and free testosterone. Which of the following statements about non-classical congenital adrenal hyperplasia due to 21-hydroxylase deficiency is false? So this question is basically to test your knowledge about adult or late onset congenital adrenal hyperplasia. So all of them are true except one, which is false. Let's read through. Elevated 17-hydroxyprogesterone following ACTH stimulation test to more than 30 nanomole per liter confirms a diagnosis of NCCAH. The exclusion of PCOS morphology by ultrasound is essential to suspect adult onset congenital adrenal hyperplasia, which she has a 1.5 to 2.5% risk of having a child with classic 21-hydroxylase deficiency. And about 40% of cases with adult onset congenital adrenal hyperplasia have concomitant PCOS, or about 20% of cases have low basal cortisol level. Which one is false? Which of the statements is false? So that means that the rest would be true. Fantastic, yes. What is false is that you would need to exclude PCOS. No, we've just said that both conditions can coexist. And actually, option D says about 40% of cases with adult onset congenital adrenal hyperplasia have concomitant PCOS. Yeah, exactly. Having said that, what is the best management strategy in this case? Is it weight reduction, use of oral contraceptive pills, anti-androgens like spironolactone, glucocorticoids to suppress adrenal androgens, or metformin? So if you believe that this patient is having adult onset congenital adrenal hyperplasia, how would you treat her with? Glucocorticoids, 33% of you said you would start her on glucocorticoids, and 51 said we would use oral contraceptive pills, which is the right answer. At another stage, you would do a weight reduction, metformin, anti-androgen. Yes, I mean, we do all of these cocktails, but the idea of this question is that you do not treat an adult onset congenital adrenal hyperplasia with glucocorticoid, except in a particular situation, let's say in pregnancy, and a female fetus. But in other conditions, the mainstay of the treatment of this case is the use of oral contraceptive pills. And I'll explain in this condition, well, first of all, you do not need to go to the actual exam without revising the steroidogenic pathway. And the most common congenital adrenal hyperplasia causes is a deficiency in 21-hydroxylase. The second would be the 11-beta. So just make sure that you're familiar with this steroidogenic pathway. What I wanted to tell you is that the use of oral contraceptive pills is really important because the OCPs will suppress the LH and subsequently the ovarian androgen production. It will stimulate the hepatic synthesis of sex hormone binding globulin, and therefore the free androgen concentration will be less. They will cause a reduction of adrenal androgen synthesis and will decrease binding of androgen to their receptors. There is an increased clearance of testosterone with the use of oral contraceptive pills, and they cause a mild inhibition of the pilosebaceous 2-to-5 alpha reductase, the enzyme important in converting the testosterone to the most active form, the DHT. So in this case, we will definitely use the oral contraceptive pills. And actually, I use later on, I add on an anti-androgen. All right. The case number 9, this is a 39-year-old lady with a past history of migraine headaches and fibrocystic disease of the breast, presented with hot flashes, night sweats, mood irritability, vaginal dryness, and irregular menstrual cycle for the past 7 months. Which of the following lab values for LH or FSH taken 1 month apart would be indicative of primary ovarian insufficiency? So the first number is, let's say, a month ago, and now the second figure is like a month later. So is it the FSH before and after, LH before and after, or FSH high then low, high and then high? So what would be your intake? Okay, so I will go, the 57% said it's the last question, which is the correct answer. So if I have a high elevated, first of all, I depend on FSH, not LH. Okay, that's one thing to keep in mind. Number 2, if I have somebody who is having the symptoms of hot flashes, night sweats, mood irritability, vaginal dryness, and irregular on 7 months, I would expect her FSH to be elevated. And if I see the first figure elevated, I would need to repeat it again in a month later. So both should be elevated, not high at one stage and then reduced. Because women in general, they go through phases, so many phases, we go through it, but then in premenopausal and going through menopause, we will have an FSH elevated and it will continue to be elevated a month later. All right, so the same lady, given the attached result, now we have a results done 1 month apart. Which of the following treatment regime is indicated? Oral estrogen progesterone, transdermal estrogen, transvaginal estrogen, oral progesterone, estrogen, progesterone are contraindicated in this case. What do you think? Yes, absolutely. Absolutely. So in this case, like 55% of you mentioned that we will have the combined oral contraceptive pills. Let me just, yeah. So oral contraceptive pills will mean that she will have the estrogen and progesterone. She is definitely hypoestrogenic, so she will need to have some estrogen, and she will need to have some progesterone because she has the uterus is intact unless it was mentioned that it has been removed. The estrogen, progesterone are contraindicated in this case? No, it's just because migraine headaches and fibrocystic disease of the breast are not the cases that we would stop her from having the HRT. Oops, sorry. Yeah. Fine. So this is another case with 36-year-old lady who had pelvic radiation for treatment of cervical cancer. Her period stopped and her FSH is 100. She has no symptoms. But what would be the most correct statement with regards to HRT? She doesn't have the hot flashes, nothing like that. She's 36. She is definitely menopausal, and she had a past history of cervical cancer. Do you think she cannot take HRT because of her cancer history? Well, she should wait a year until she would start HRT, or she should take HRT until the average age of menopause, or she should take HRT for 5 years only, or she does not need HRT because she has no symptoms. Okay, that's correct. So 62% said that she should take an HRT until the average age of menopause. So that's quite true. So I just wanted to highlight that patients with cervical cancer is really not, this is not necessarily estrogen sensitive cancer. And it is mainly...
You have 5 minutes only.
Okay, all right. So it's mainly the estrogen sensitive cancer that we cannot give the HRT. So this is just based on the North American Menopause Society. Those are the real contraindications to HRT. Any patients with unexplained vaginal bleeding or liver cancer, liver disease, or breast cancer, endometrial cancer, or ovarian cancer, prior cardiac coronary heart disease, or personal history of inherited high risk of thromboembolic diseases. This is the last case where 53% had the past history of hyperlipidemia and hysterectomy for uterine fibroid, strong family history of osteoporosis. The patient is keen on HRT, but she cannot tolerate the night sweats and mood swings. Which formulation of HRT would you advise? Bioidentical hormones, oral estrogen, progesterone, transdermal estrogen only, SSRI, or selective estrogen receptor modulator like raloxifene. Okay, so majority said it's transdermal estrogen, which is the right answer. Because she has the hysterectomy done, she does not need the progesterone. And the transdermal estrogen is really needed in this case because of the risk of osteoporosis, and she needs it for the mood swings and the night sweats to replace her estrogen. I will just have one slide about the SERM and the SERM and the tibolone that I will share with you at the end. The same patient, if you start on HRT, which of the following tests would you expect to worsen? Do you want to answer that, or I can just tell you the answer right away, Mr. Chairman? I think if you can just answer quickly for this, it's an easy thing. Patients with HRT will, especially those who are having the progesterone, will have worsening of their lipids profile, especially the triglycerides. However, this patient will be having the estrogen and transdermal, So one wouldn't expect any deterioration of the lipids profile. So I will conclude with this slide just to give you a little bit of a differentiation between the tibolone, which is a synthetic steroid with estrogenic metabolites, versus, and it is mainly for the vasomotor symptoms, whereas the raloxifene is a SERM and mainly for the osteoporosis prevention and treatment. You need to be aware that both of them can reduce the risk of fractures. However, there's the tibolone can increase the breast cancer risk recurrence and increased risk of stroke, whereas the raloxifene can increase the hot flushes and increase the venothrombotic event. Just make sure that you read through the differences between raloxifene and tibolone. I think with that, I'm going to conclude. Thank you very much for your attention. And I will just see if you have any question related to any of the cases.
Thank you very much, Dr. Huda, for a very fabulous session. I think we do have some questions, and let us start with a question from Dr. Jinan Ubaid. She's asking you, Dr. Huda, how OCP will help in restoring estrogen in hypothalamic amenorrhea?
Okay, so I can answer you without referring to that particular case. So we need to make sure that those patients with hypogonadism, regardless whether it's hypogonadotropic or hypergonadotropic hypogonadism, they need estrogen, especially if they are in the premenopausal age group. We need estrogen for whether it's for induction of cyclical shedding of the endometrial or for secondary sexual characteristic, as well as for bone. So it will not actually treat the condition, but we need the patients, we manage them with this because they need that hormone that is deficient, especially also for the breast development and so forth. Does that answer your question, Doctora? Hope so.
I think so, yes. Thank you very much. Dr. Raneem Antijani, she asked you a specific question regarding your case scenario number 7. She stated that we should send DHEA level before imaging or not.
Okay, let me go through case 7. So the question was,
should we send DHEA level before imaging?
What level?
Dihydroepiandrosterone sulfate.
Okay. No, not necessarily. I'm happy with just having the free androgen index. I mean, this patient is clearly she's having, and I know this case, she has ovarian tumor secreting androgens, and you have the free androgen index, or if you have a free testosterone, that would be enough. If you have a doubtful result, then you can ask for a DHEA if you think that the origin of the androgen is from the adrenal. Well, pelvic MRI will actually show the ovaries as well as the adrenal. You need to be mindful of both origins of the excess androgens.
Fabulous. Okay. Another attendee is asking if a girl presents with delayed puberty and growth, for example, you suspect Turner syndrome, which one should be started first, growth hormone therapy or estradiol in order to gain height? And how would you approach her?
Okay, so I didn't put a case on Turner, hypergonadotropic hypogonadism. However, those patients are usually, they get to the attention of the pediatric endocrinology colleagues or possibly to the gynae. But the principle of management is that after confirming the diagnosis with the genetic testing, then you would need to try to give them a chance. Of course, you would need to do an oral contraceptive. You need to give them oral contraceptive because they would need to replace and supplement their estrogen. And whether you would need to give a growth hormone, this is an off-label use of growth hormone in these people, because not every Turner will have a growth hormone deficiency. So you need to make sure that are they actually deficient, or they're actually having just a growth retardation because of the Turner syndrome. Most of the pediatric colleagues will give both of them, the OCP as well as the growth hormone, to a certain duration.
Good, excellent. Dr. Khadija Diyan, she's asking you, Dr. Huda, in polycystic ovarian syndrome, for how long do you have to continue to give oral contraceptives?
That's a tricky question. Yes, because we tend to give them, okay, there is no duration specified by guidelines. However, I can tell you that what I tell my patients is that go through oral contraceptive pills for 6 months, and then go take a drug holiday for 3 months and see how things are going, 3 to 4 months. Maybe things will become better. And knowing, we tell the patients, because we want to make sure that they have really good adherence and compliance with OCP for a long period of time, that we do not have a cure for PCOS, but we can improve the clinical things. And honestly speaking, the management, the cure or a transient cure of PCOS would be pregnancy, or anything that would simulate pregnancy. So those single ladies, go ahead and get a husband, and then your PCOS will be cleared, because your pregnancy will put the ovaries at rest. And this is what OCP will actually do. They will put the ovaries at rest for the duration that the patient is using them. And that will stop the ovulation altogether for that duration. And once you stop taking the OCP, it takes about 6 weeks to 8 weeks for the hypothalamic ovarian axis, thalamic pituitary ovarian axis to return to its normal. And then you can recheck whether that the pulses of the LH and FSH became back to normal again. During that time, we strongly encourage patients for weight reduction, whether through diet and exercise or through the newer agents that we're all familiar with.
Good, fantastic. Right, okay. An anonymous attendee is asking you probably a question slightly out of the context of your cases, but she's asking what is the choice of HRT OCP in a patient with migraine with aura?
All right. Before getting into the management of HRT, management of menopause, we need to make sure, why am I starting the patient if she is menopausal on HRT? Is it mainly for vasomotor symptoms, or is it for bone, or is it for dyspareunia? Because we can give something locally to improve things. But migraine can be very tricky. Migraine nowadays can be managed through neurologists with the newer agents that will help reduce the attacks. And if I want to start anything of HRT, I would first make sure that her attacks are under control, because HRT will worsen the migraine attack. So I would work closely with a neurologist first to control the migraine, and then I would add on the HRT if it is indicated and no contraindications, as I mentioned.
Good, okay. Dr. Suad Al-Mandari asks you, Dr. Huda, a patient with hypothyroidism, you started her on treatment, thyroid function test normalized, how long it will take for the menstrual period to resume and become regular?
Okay, so if the irregular cycles is not due to PCOS and it is mainly due to abnormality of the thyroid functions, then it takes about 2 to 3 months for the periods to become regular. But you have to make sure that the TSH is steady first. and steady, whether on treatment or without, with treatment, of course. So you don't actually remove her on, stop the treatment. So it has to be, the TSH needs to be steady on that particular dose of thyroxine. And then it will, I mean, every patient is different, but I would say 2 to 3 months, it will become normal, regular.
Fantastic. Okay. Dr. Khadija Dayan again asks you, in non-classical congenital adrenal hyperplasia, do you use just OCP or with glucocorticoids?
No, I use OCP and anti-androgen. The glucocorticoid will actually cause, in some patients, they might cause more metabolic disturbances. And those patients are really at a higher risk of, if she's not already having PCOS, then with glucocorticoid things might worsen. Hirsutism might worsen, even though the testosterone might suppress a little bit. So all guidelines will actually stop indicating glucocorticoids for the non-classical or for the adult onset, and it is only reserved for the classical congenital adrenal hyperplasia or in the non-classical pregnant woman and the fetus is female.
Okay, right. Dr. Salwa Azar asks you about a lady, 25-year-old female, primary amenorrhea. She has pituitary ion deposition secondary to iron overload from multiple transfusion due to thalassemia. She has growth hormone deficiency and very low FSH, LH, and estradiol, and low bone mass. What to start first? Estrogen and progesterone, and later growth hormone, or you do otherwise?
How old was the patient?
25.
No, definitely estrogen, progesterone. And then you need to make sure that if the bones have closed, the epiphyseal have been closed or not. It's always tricky, those patients, because they might have multiple organs that are with the hemochromatosis that are affected. So you would need to work with a hematologist as well as with maybe somebody with a metabolic medicine interest. So I would definitely start her on the OCP first and restore her estrogen reserves.
Right. Dr. Lujain asks you another question. When would endometrial hyperplasia be a risk? And what would be the duration of amenorrhea before it becomes a risk?
We don't know exactly when, but we know that if the endometrial hyperplasia increases because of the lack of shedding and the unopposed elevation of estrogen, you know that PCOS, they have an elevated estrogen level. They need to have that endometrial withdrawal bleeding, if you will. We do not know when would it be a risk, but it is generally endometrial hyperplasia and endometrial cancer is the risk of it in PCOS is maybe 2 to 3 times those who are not having PCOS. That's why it's really important to make sure that the patient's having a withdrawal bleeding not more than 3 months of secondary amenorrhea.
Okay. We don't seem to have any more questions. Thank you very much, Huda, for being with us and delivering a very fantastic and really very informative session. Thank you very much, Huda.
Assalamu alaikum wa rahmatullahi wa barakatuh. We will move to second session about calcium and parathyroid disease. Our Dr. Thamer, he is well known to us and in our area. He is consultant in endocrine and diabetes and metabolism in Jaber Al Ahmed Hospital in Al Kuwait. and he is also a clinical staff in Dasman Diabetes Center, and he is Vice President for Kuwait Osteoporosis Society, and he is chair of the Kuwait Endocrine Diabetes Board Examination Committee. Welcome, Dr. Thamer, and it is your turn.
Thank you, Dr. Ali. Appreciate the kind introduction. Also, thank you for the course organizing committee. We can start right away with the today's talk. So we'll go ahead and start questions regarding bone disease. Okay, so metabolic bone disease and calcium. So as you used to, we're still going to start with the questions. So question number one. This is a 30-year-old man with a history of hypothyroidism and hypertension, presents to established care. He moved, so he needs a new physician to take care of him. He's taking levothyroxine 75 microgram daily and hydrochlorothiazide, which is thiazide diuretic, 25 milligram daily for blood pressure. He has a history of a right femur fracture requiring rod placement a few months ago after falling on the street, and you can see here on the picture, this is very obvious. He has a long-standing history of poor dentition, diffuse joint, bone, and muscle pain. He has and decreased also exercise tolerance dating back to childhood. His height and weight give him a BMI of 21.5, and examination finding is normal. Laboratory test shows an hemoglobin 12.5, which is almost normal, calcium with the albumin 43, alkaline phosphatase 13, that's really low, phosphate is within normal on the lower side, 0.8, creatinine normal, TSH slightly on the higher side, and the total vitamin D, that's 40 nanograms or almost 100 nanomoles, which is normal. So which of the following is the most likely cause of this patient low alkaline phosphatase? Is it celiac disease, hypophosphatasia, hypothyroidism, recent fracture, or X-linked hypophosphatemia? We can start the polling for 20 seconds. Okay, so down to see the results. So vast majority said actually the correct answer, which is the hypophosphatasia. So thank you. So excellent work. So the generally low alkaline phosphatase, there's plenty of reasons for alkaline phosphatase. And this is just a list of a lot of these conditions. On the top of the list, as you can see, is hypophosphatasia. And also low phosphate level can be cause of multiple causes. And one of them, it could be a genetic disorder causing a hypophosphatasia. So what is a hypophosphatasia? So it's a rare genetic disease. It's caused by a loss of function in the pathogenic variant in the ALPL gene, which is caused for a specific tissue non-specific isoenzyme of the alkaline phosphatase. This is what the gene stands for, tissue non-specific alkaline phosphatase, which is 95% of the total serum alkaline phosphatase activity controlled by this enzyme. So this enzyme is abundant in the bone, in the liver, in the kidney. It also is expressed in other tissues, including the cartilage and teeth. And that's when the presentation of the patient involved multiple sites where they could have deficiencies. So the main physiologic substrate of this enzyme are the inorganic pyrophosphate, or PPI, and peroxidyl 5-phosphatase, or the PLP, which is an active metabolite of vitamin B6. Now, when you lose the function of this enzyme because of the genetic disturbance on the gene, you will have a buildup of these metabolites, which is the PPI and the PLP. And as a result, because of that, you will have the low alkaline phosphatase activity, and then you will have a lot of these metabolites accumulating in these tissues where the enzymes actually works. So the prevalence of this disease is rare. So it's 1 in 100,000 population, especially in the Anglo-Saxon population, but it's more prevalent in Manitoba and Canada, where 1 of every 25% actually is a carrier of this disease. Inheritance is autosomal recessive for the infantile forms, and either could be autosomal recessive or autosomal dominant in the milder adult form with variable penetrance, meaning could be presented, could not be presented. The clinical presentation and the severity of the hypophosphatasia also depends on largely on the variant of the gene and also the penetrance of the gene. So clinical data in adults, and this is obtained by global hypophosphatasia registry, majority are females. Vast majority will develop pain and general pain in the body. And a lot of them could have orthopedic procedures because of joint issues or fractures. And they could have also recurrent or poorly healing fractures because of these conditions. Foot fractures are reported in 1 to 23 adult patients with hypophosphatasia, so it's very common to develop these kind of fractures. Bone mineral density, lumbar spine by the BMD is not really reliable due to abnormal matrix quality because of the accumulation of these metabolites. So you cannot really depend on DEXA scan in these individuals. The range of BMD values are wide. It could be good, it could be bad, but it doesn't really translate well with the risk of a fracture in these individuals. Treatment, we don't have a curative treatment for HPP or hypophosphatasia. But there are systemic treatments which are important, and they definitely require a multidisciplinary team, whether it's drug therapy or procedural therapies to manage their condition. So one of the therapies that are available is the enzyme replacement, which replaces the tissue non-specific alkaline phosphatase, which is the enzyme that is deficient in these individuals. It's called aspartase alpha, and it's actually recently available in the region. So you might be approached by the makers of this therapy, Strinzink, which is a human recombinant enzyme, tissue-specific alkaline phosphatase enzyme. It's approved for patients who have pediatric onset hypophosphatasia to treat bone manifestation of the disease itself. The studies that worked and used this therapy in infants and in children showed that therapy can improve skeletal mineralization and also other abnormalities like growth, mobility, respiratory function, survival, and pain, with benefits sustained up to 7 years of therapy in that situation. It's generally well-tolerated therapy. Most common adverse events were mild to moderate injection site reaction because it's taken as an injection. What about other answers? So profound hypothyroidism can cause low alkaline phosphatase, but his TSH is only slightly elevated. Celiac disease can cause also low alkaline phosphatase, but this patient does not really have any other deficiencies. So he doesn't have anemia, his vitamin D is normal. Whether this could be a pathogenic variant of the X-linked hypophosphatasia, well, it's a causes rickets, which is with a low phosphate, not a low alkaline phosphatase. So it's a different diagnosis, different observation of findings. And the recent fracture can result in elevated alkaline phosphatase, but not low alkaline phosphatase. So going to question number 2. This is a 40-year-old woman with end-stage renal disease from systemic lupus erythematosus who developed severe diffuse bone pain and fractures. She has been undergoing hemodialysis 3 times a week for more than 10 years now. Over the past several years, her serum calcium and PTH levels have increased dramatically and have been resistant to high doses of cinacalcet. Her laboratory shows that her calcium and albumin levels are so it gives her significant hypercalcemia. Her serum phosphorus is on the higher side. Her total vitamin D is slightly low. Her intact PTH is hugely elevated, 5,300 nanograms. The upper cut limit is 65. Alkaline phosphatase is very high. That's almost 4 times or more than 4 times actually, the upper limit of normal. And magnesium is within normal range. So because of worsening bone pain and uncontrolled hyperparathyroidism, she went about for a 3.5 gland parathyroidectomy. A few hours after surgery, she presented to the ER with severe muscle spasm and paresthesia. Her weight is about 70 kilos. Her laboratory values showed that her serum calcium is 2. Again, her albumin is 38. That gives her a corrected calcium on the low side. And serum phosphate was still within the normal range. So we need to treat this patient's probable hypercalcemia. So in addition to giving her calcitriol therapy, which of the following is the best next step? Would you give initial therapy with oral calcium or calcium carbonate with no subsequent therapy? Or you would give her intravenous bolus of 100 milligrams of calcium chloride, and then you give her continuous chloride infusion with a 0.5 milligram per kilogram per hour. Or you would give her IV bolus of 1 gram of calcium chloride, and then continue calcium chloride infusion at the higher rate, 2 milligrams per kilogram per hour. Or you give her intravenous bolus of 150 milligrams of calcium gluconate, and then continue as an infusion of calcium gluconate about 1 milligram per kg per hour. Or give her intravenous bolus of 500 milligrams of calcium gluconate, and then continuous calcium gluconate infusion to achieve the total dose of 2 grams calcium over 24 hours. So which one you want to choose? Let's start the polling. Okay, so the majority chose initial therapy, intravenous bolus of 150 milligram calcium gluconate, subsequent therapy, continuous calcium gluconate infusion of 1 milligram, and you are absolutely right. So let's see why that choice was correct. So the patient, what did she develop? She developed a hypocalcemia in the setting of a hungry bone syndrome after a parathyroidectomy, which can be expected because of the very high level of alkaline phosphatase, the very high level of calcium, the very high level of parathyroid hormone. So intravenous calcium should be considered for patients presenting with clinical features of hypocalcemia from any etiology. So that's the choice number one, which is oral. That's absolutely not correct. So when you have a patient developing or following parathyroidectomy regarding hyperparathyroidism, so if so he could be developing hypoparathyroidism, and that will be not because he would have a low parathyroid hormone and a low calcium, and that will be a hypoparathyroidism. Or he could have a persistent hyperparathyroidism, meaning it's not curative surgery, where his parathyroid will be high and total calcium also will be high. He could have later on a recurrent hyperparathyroidism, meaning it's within the mild normal range of calcium, but eventually he will move to persistent hyperparathyroidism as his calcium will go up and his PTH will go up. So that would be considered as recurrent hyperparathyroidism. Patients with hungry bone syndrome are patients with a very low calcium level, but also their parathyroid hormone could be normal or could be even elevated in that situation. Because why it's not low? Because they still these patients will probably have an injury to 1 or 2 or 3 even parathyroid glands, but still will have a functioning minimal amount of thyroid or parathyroid hormone. So it wouldn't be completely suppressed, but it would be that they would have some action of the parathyroid because of the remnant of the parathyroid that is left, whether it's 1 or 2 or half of a parathyroid. So typically, when hungry bone syndrome develops, it's characterized by postoperative hypocalcemia, inorganic phosphate values to be low, incorrect value here, and hypocalcemia that lasts for more than 4 days, requiring high doses of calcium supplementation despite optimizing vitamin D. That's also tells you that this patient is going to he is in the hungry bone syndrome. So in case of the patient with end-stage renal disease, the treatment of activating vitamin D is always necessary in these individuals. So surgical treatment of a primary or a tertiary hyperparathyroidism, when you resect 1 or more overactive parathyroid gland, this causes sudden cessation of bone resorption. And when you have a sudden cessation of bone resorption, because you have a lot of bone resorption that was going on during the primary or the tertiary hyperparathyroidism, and in these two situations, you have an autonomous function of the parathyroid gland. So when this shuts down completely, your bone stage goes into cessation complete of bone resorption. So you will have a much depletion of the serum calcium, circulating calcium, and also phosphorus, and even magnesium, because the hungry bone is actually tries to remineralize since the bone resorption has stopped. So he's not breaking down bone anymore. And now he's going into remineralization phase. So requiring all these minerals from the bloodstream into the bone. So patient at risk for severe hyperparathyroidism preoperatively. So who's at risk? Patients with severe hyperparathyroidism before surgery, patients with very high levels of alkaline phosphatase, and also patients who develop osteoarthritis fibrosis cystica, which is a brown tumor, as we call them. They're available. You can see them on skeletal radiograph. And the reason why they develop these changes is actually empty bones. So areas of the bone, because of severe bone resorption, they become filled with only soft tissue rather than bone tissue. And that's what they call osteoarthritis fibrosis cystica. And this is one form of how bone, or one stage or one type of bone disease, or renal osteodystrophy, we call them. In severe cases of hungry bone syndrome, you need to have intravenous or high-dose oral calcium, and also vitamin D may be needed for many weeks or even months. And you need to start them on IV, or even at the same time, you can start them with oral calcium. But for severe cases, you definitely need IV. So symptomatic, so patients they have hypocalcemia, so I'm sure I'm not really saying something new here. So symptoms of low calcium, which will require IV calcium, are carpopedal spasm, paresthesias, bronchospasm, laryngospasm, tetany, seizures. And when they have these findings of positive Chvostek sign or Trisori sign, these are very important. When they have cardiac changes like bradycardia, prolonged QT intervals, impaired cardiac contractility, these are the emergency situations, need to act very fast. Patients also, you can treat them with IV calcium even if they are asymptomatic. but they have to be with marked hypocalcemia, meaning their corrected calcium or adjusted calcium has to be less than 1.8 or even less than 1.9. That's considered a significant level that you need to treat with an IV. Because if you don't, then you will have increased risk of acute development of life-threatening features, especially laryngospasm and seizures. So using oral by itself is not an option. Calcium gluconate is preferred over calcium chloride. Why? Because the later, which is the calcium chloride, has to be given in a larger veins and is more likely to cause vein sclerosis and tissue necrosis if it's extravasated. So that's like we don't like to use calcium chloride in these individuals. So that's why answers B and C are incorrect. So the dosing of 1 milligram per kilogram per hour, that gives them a total dose for this individual who's 70 kilos for about almost 1,700 milligrams daily, which is an appropriate dose as a replacement, since a daily requirement for a person would be a maximum about 1,200. So here we're giving him even extra amounts of calcium. That will be sufficient to his replacement after we give them the bolus therapy. And you can even give them a higher rate, like 1.5 or even 2 milligrams, if you see that the calcium deficiency is so profound and you need a much larger dose to get it corrected. The last option, which was the calcium gluconate with 500 milligram, that's a huge dose, dangerous. We should not use it in this situation. Okay, question number 3. A 65-year-old woman presents for follow-up for osteoporosis diagnosis that was done last year, or 1 year ago, before the initiation of aromatase inhibitor therapy, which she's using it for a diagnosis of ductal carcinoma in situ, and she had lobectomy of her breast and radiation therapy also following that. She takes anastrozole, and she's planning, or they're planning to keep her on it for a course of 5 years. She already has received a dose of zoledronic acid, 5 milligram intravenously 1 year ago. Her BMD, prior to the treatments, before she got all the therapies, was significant, that showed a T-score of minus 2.5 at the lumbar spine, minus 2.9 at the lumbar spine, minus 2.2 at the femoral neck, and minus 2.4 at the total hip. Her BMD report this year, after a year, performed on the same machine, demonstrated significant improvement. It showed that T-score has improved, so 15% gain in the lumbar spine, and also the femoral neck and the total hip gained 10% more. And I'll show you the figure in the question here. So this is the picture of the spine, and this is the picture of the hip. Now, which of the following is the best next step? A, inquire about the calibration of the densimeter. 2, or B, request PET-CT image due to concern that this patient could have metastatic disease, given her values. Request a reevaluation of the lumbar spine bone densitometry, or request a reevaluation of the total hip bone densitometry, or start a drug holiday since she got 1 dose and density is fine, so let's give her a drug holiday. So which one is correct? Okay, so I see the confusion here, right? So people are spreading their answers. So majority said it's either A, inquire the calibration, or C, request an evaluation lumbar spine, thinking that probably our people think that lumbar spine has an issue. So the correct answer is actually A, which is require about the calibration of the densimeter. The reason why. So reviewing the images and the numbers from the DEXA scan is always important. So you have to do it when you're doing a follow-up on a disease, on a therapy of a patient, particularly when the results do not make sense. So why did it make sense? Because the increase in the bone density is completely above the expected for a single dose of zoledronic acid. She gained 15% in the lumbar spine, 10% in the hip, which no way that zoledronic acid can do in 1 dose. This is a long-term effective anti-resorptive treatments with bisphosphonates. So you can see it showing you here, risendronate, alendronate, zoledronic acid, and denosumab. All of them are anti-resorptives, okay? And the duration of treatments are between 6 years to up to 10 years. Look at the change in lumbar spine is between 11 to 15%. That's 6 to 10 years of treatment, not 1 year, where in total hip is actually much, much less, okay? So definitely with the changes that happened to this patient, it's unlogic that this because of the therapy. So there's something wrong happened. So bone density images do not have any, so why we didn't really want to do re-evaluation? Because there's no obvious inconsistencies, but there is actually labeling issues in these images, and I'll show you why. So with the follow-up, so A is the baseline, or the first DEXA scan, The B is the follow-up. And what the problem happened here is the labeling of the vertebrae that was done incorrectly. And this is easy, can be done by, the analysis can be done correctly. We don't need to go to send the patient back to do another DEXA scan. We just need the machine or the person who's doing the DEXA scan to reanalyze the data again. So what happened here is that this is the correct labeling of L1, L2, L3, and 4. But when they did the follow-up, it's actually they moved all these levels one level higher. So L4 is actually L3, not an L4. And this one here is not L5. This is L4, but it's missed. And as you know, the spine, as you go down in the spine, the density is higher. And as you go up, its density is lower. So this patient did not really have a good evaluation of the spine. And you can look at the floating ribs, gives you a good clue that this patient is this spine is a T12 or L1. So you can see here, this part right here is actually a floating rib coming out from the T12, which is this one. It's not an L1. And this is also floating rib coming from the other side of T12. Also in the hip, there's another measurement mistake. So positioning of the total hip. So this is the total hip mark. So you can see here, what's missing is actually the lower part of the femur, which is right here. So the lower part ends, it should be about 2.5 centimeters below the lesser trochanter. And in the follow-up, it actually was cut. And that's what actually created issues with the management. So that's the correct answer was we need to look at the calibration and reanalyze the data in that situation. So metastatic disease to the bone is not really the issue here, even though it's common in breast cancer. But on the X-rays, you can find it as a lytic lesions if it's actually metastasis from a breast. But in breast metastasis to the bone, you can find them on X-rays as lytic lesions. Sometimes you find them as blastic or mixed, but majority would be lytic lesions. You can easily find a lytic bone lesion on a regular X-ray. The patient is aromatase inhibitor therapy, which is known to cause bone loss, and treatment should not be continued because of that reason, because we can give them therapy to improve their BMD, and they require this therapy to survive breast cancer. Okay, next question. This is a 65-year-old woman with a long-standing type 2 diabetes concerned about her bone health. She has no history of low trauma fractures. She has been on hemodialysis for the last 40 years because of diabetes-related complications, which also include lower extremity peripheral neuropathy. Her medications are glargine, daily Lispro before meals, atorvastatin, metoprolol, calcium acetate, and gabapentin. She does not smoke cigarettes or drink alcohol. Family history is negative for osteoporosis, including no parental history of hip fractures. She has a palpable thrill over left forearm for the AV shunt. She has a normal spine curvature, no palpable bony tenderness over the tibias, no ulcers, no lesions on her feet, has an absent sensation in the monofilament testing in both feet, and the rest of the physical examination is non-contributory. These are her laboratory values. So her calcium is 2.5, albumin 36. That's almost a normal calcium. Phosphate in the higher side. Creatinine is very high given her chronic kidney disease or end-stage renal disease. Also urea. Her alkaline phosphatase is slightly above range. Her parathyroid gland is very high. And her vitamin D is very low, 27.5. Her DEXA scan shows that her lumbar spine T-score is minus 1.2. Right, the femoral neck on the right side is T-score is minus 2. Right total hip is minus 1.6. And the left forearm is actually the lowest of them is minus 2.8, which is the 1/3 of radius. So which of the following treatments would be the best to address the patient's underlying bone disorder? Is it alendronate, teriparatide, cholecalciferol, calcitriol, or sevelamer hydrochloride? We can start the polling. Okay, also seems like it's not a full answer for everybody. The 36, the majority answered is calcitriol, but the next choice was the cholecalciferol. And actually the correct answer is cholecalciferol. So definitely she's vitamin D deficient, and we'll explain how this is actually shows up. So the following changes are consistent that this patient has what we called before is osteitis fibrosa cystica, and also could be an osteomalacia. Why is that? So she has a low bone density, okay? But she has a low vitamin D level, which is very low, 27.5 nanomoles. And she has PTH that's 5 times the upper normal range, which is very high. And she has a low bone density. And mean bone density is actually in the 1/3 of radius, which is what? Related to the effect of the very high PTH level on cortical bone that's in the 1/3 of the radius. That shows the effect of the PTH that is very high and the effect on bone density that is a majority was lost in the cortical part and the forearm. We don't have on this question the bone-specific alkaline phosphatase. If we ordered it, you will see that it's going to be very high because her regular alkaline phosphatase is slightly above the normal range. So the responsible thing to do at this point is give her vitamin D replacement because that's what she is right now. She has a huge PTH showing densities deficiency, mostly in the cortical bone in the forearm and very low vitamin D level. So what could be disturbances in the bone and minerals in patients with end-stage renal disease? So things that can happen wrong in these patients, they could have hyperparathyroidism, they could have hypocalcemia because they could not able to concentrate calcium and reabsorb calcium from the kidney, so they waste it. Also because of other reasons, because they don't have enough calcitriol, which is the activity level or the activity form of the vitamin D, and that's also another reason why they could have a hypocalcemia. They would have hyperphosphatemia, definitely, and they could have a variable alkaline phosphatase. It also depends on the original pathology of the bone itself. Now, they could have skeletal disturbances. They could have osteoporosis, a typical osteoporosis that can happen to anybody. But also they could have specific issues related to bone health, which we call them renal osteodystrophy changes. And they are bone diseases that are very specific because of end-stage renal disease. One of them, as we said, is osteopathis fibrosa cystica. What does happen? These patients would have a huge bone turnover. So that means they will evacuate a lot of their bone because of bone resorption, but they could have a normal mineralization, meaning the amount of calcium still within normal range in the bone, but normal mineralization, I'm sorry. But the bone resorption part is very large. That means leaving only soft tissues instead of bone within the bone itself. Also, they could have osteomalacia. And with osteomalacia, the bone turnover is actually low. And also, they would have an abnormal mineralization. So low turnover of the bone and also low mineralization of the bone. So minerals would be entering the bone in a different rate or lower rates. Also, they could have an adynamic bone disease, which is also, again, can cause bone turnover to be deficient. But also very specific with adynamic bone disease is that would be acellular, meaning they would not have enough bone cells to build up bone. And the issue is that with the formation of the bone, and the bone cells is actually the one that is actually causing this issue. And you can have a mixed form of all these three together, which makes it even harder to understand and more complicated issue. So this is kind of the patterns of these renal osteodystrophy changes that can happen with patients with end-stage renal disease. So osteotitis fibrosa cystic, as you mentioned, bone turnover is huge, and bone mineralization could be normal, maybe slightly even elevated. But what they have characteristically is that they would have an osteotissue, which is non-mineralized new bone formation in these individuals. Bone mass could be anywhere within the renal osteodystrophy because they are not really osteoporosis disease. They are metabolic changes that can develop because of end-stage renal disease. So bone mass, we cannot really depend on it to know to understand the situation of the bone disease that they're developing when develop end-stage renal disease. Adynamic bone disease and osteomalacia, both of them, they will have turnover to be very low. The difference between them is the mineralization. With adynamic bone disease, they would have a normal mineralization. And because the problem is with the bone cells themselves, so it will be acellular bones. When osteomalacia, they will also have low mineralization and at the same time, low bone turnover. Also with osteomalacia, they will have a lot of non-mineralized, newly formed soft tissue within the bone that is non-mineralized well to be a normal bone tissue. And you can have a mix of everything together. And this will be the tricky part when you're diagnosing it. So this is what happens to these individuals when they develop renal osteodystrophies. They could be either osteopathis fibrosa cystica, adynamic bone disease, or osteomalacia. Now, this is a complicated diagram. I'm only going to mention about these three phenomena, which we see them in the bone cell. So in dark here, this is actually a bone cell. And they could have, as we said, osteomalacia, adenomatous bone disease, and osteopathia fibrosa cystica. With osteopathia fibrosa, the main driver is the huge amount of high PTH. Increases the bone turnover to a way that only will form some soft tissues within the bone. And the mineralization could be normal, but they were absence of the normal regular bone resorption. Or bone resorption would be excessively that they wouldn't even have time to build any bone. So that would be the effect of mainly of the high PTH. Osteomalacia is mainly developed by the effect of acidosis that comes from chronic kidney disease. So it's a more toxicity to the bone because of acidosis, and they will have low mineralization and also low bone turnover. Adenomatous bone disease is a little bit more complicated because they could have a PTH resistant because of decrease in PTH receptors, and this is because of the high phosphorus retention that they could develop. Also, could be a trigger also of high FGF23, which is a phosphoryuric molecule that actually dumps urine or try to clears out the phosphorus of the body and also wastes it from the bone itself. And this is also could be another reason to form the adenomatous bone disease. So testing for BMD in patients with chronic kidney disease hasn't been part of the guidelines of management of chronic kidney disease until very recently. So in the KDIGO, what they decided is that from the guidelines 2017 onwards, if you have a patient with CKD stage G3A with evidence of metabolic bone disease, meaning the metabolic changes that we saw in the blood test, and other risk factors for osteoporosis, then BMT testing can be helpful to assess the fracture risk. It's suggested if it will actually impact the treatment decision. Because for a very long time, BMD testing wasn't really part of evaluating metabolic bone disease in chronic kidney disease because renal osteodystrophy predominates the regular osteoporosis in that situation. Also, in these same individuals, it's responsible to perform the tetracycline-labeled iliac crest bone biopsy if knowledge of the type of renal dystrophy will impact also the treatment decision. But still, not all many places actually can do this biopsy, but it will be helpful to guide you exactly what would be the issue with the bone. Treatment, you need to lower phosphate levels towards normal range. And you need to have look for modifiable risk factors, especially rising parathyroid levels. You want to get them as low as possible, and also try to use calcitriol and vitamin D analogs in patients who have advanced stages of kidney disease, and also with severe or progressive hyperthyroidism. You need to treat them quite good with that therapy. And if they have a biochemical abnormalities and a low BMD or a fragility fracture, then you can think of, you consider the magnitude and reversibility of the biochemical abnormalities and also the progression of CKD. And you might also think of doing a bone biopsy, but then these patients who have fractures specifically, they need to be on some sort of therapy, either anabolic therapy if they have a low bone turnover, or anti-resorptive therapy if they have a high bone turnover condition. Okay, next question. A 50-year-old man referred for the evaluation of a newly identified hypercalcemia after presenting to his primary care physician with symptoms of fatigue and polyuria for the last 6 months. He is otherwise healthy, has no history of medical condition. He has no history of fractures, no kidney stones, no neck radiation. He does not have, he's not taking any medication over the counter or supplements. Family history is negative for osteoporosis, kidney stones, endocrine tumors, or head and neck malignancies. EP is normal, vital signs unremarkable. A finding on examination was actually completely normal. There's a fullness over the right lower anterior neck without associated adenopathy in the neck. The rest of the exam is normal. This is his laboratory test, so his calcium level with normal albumin is 3.2. That's very high calcium level. Phosphate is on the lower side, but not low. Creatinine is normal. Alkaline phosphate is slightly elevated. Very high level of parathyroid hormone and low vitamin D. They did also a technetium scan. Parathyroid scan shows delayed uptake in the right lower neck, which corresponds to the swelling that was palpated within the neck. So which of the following is the best next step in this patient management? Refer him to endocrine surgery for minimal invasive parathyroidectomy, since you already done the scan. Start cholecalciferol and measure PTH again after 6 weeks. see if it improves. Start calcinic acid to lower the PTH. Do a neck ultrasound, or even do a renal ultrasound. So which one is correct? Start polling. Okay, so tricky question. It's not a difficult question, but it's actually a tricky question. So majority said they won't send them to surgery. Another answer was following that is do ultrasound. And the correct answer is actually do an ultrasound. Why is that? I'll tell you in a minute. So as you know, this is definitely primary hyperparathyroidism with presenting hypercalcemia. And manifestation of this disease depends on the onset and acuity or the severity of the calcium. So if it's more than 3, that means it's a severe hypercalcemia. These are typical symptoms that can develop, whether it's an acute or chronic. I'm sure you all know of them. Polyuria, polydipsia, anorexia, and nausea, they could develop with some cardiac changes like short QT interval, but even heart block, which is contrary to the hypocalcemia part, which we said. If it stays chronic, then you will have constipation, even pancreatitis and kidney stones at the end. And there are many, many causes of hypercalcemia. I'm not going to go through them, but what we care about more is the endocrine causes. There are a lot of malignancy-associated hypercalcemia, whether it's because of PTHRB, which is parathyroid-related protein, or because of effect on 1-alpha hydroxylase activity in Hodgkin disease, accumulating more active form of calcium, or even direct invasion to the bone and release of the calcium there. But the direct effects are most commonly would be a primary hyperparathyroidism, which is PTH-dependent hypercalcemia, which could be an isolated or part of a familiar condition with genetic disposition. These are other causes of hypercalcemia, whether it's drugs or granulomatous diseases and immobilization, definitely. So this patient has hyperparathyroidism. Now, main cause for primary hyperparathyroidism would be adenoma. That's almost 90% of the time it would be an adenoma. And most of these adenomas is actually a single adenoma. Very rarely it would be a double adenoma. Some of these are actually hyperplasias and part of MEN1 or MEN2A, or even some of them rarely are non-MEN genetic hyperplasias. But also carcinoma is a rare disease. And the diagnosis, at least you have to have, on the tissue level, you need to have a local invasion of the nearby structures of the lymph nodes, or even having a distant metastasis to call it as a carcinoma. There is no definite histologic description of a cell of a carcinoma of a parathyroid, unless it actually behaves in a way that cancers can do, which is the local or distant metastasis. So our patient is asymptomatic, but he does have hypercalcemia. And he actually needs to have a surgery because his calcium level, and this is the guidelines for surgery in the primary asymptomatic hyperparathyroidism. This is from the updated version from 2022. So if it's more than 0.25 of the upper limit of normal, he definitely is. And if the GFR is low, there's kidney stones, urine calcium is elevated, or patients have osteoporosis or vertebral fractures, or the age of less than 50, all these individuals, they need to go for surgery. But the problem with our patient is that there's a risk that he could have a carcinoma. Why is that? Because of the size and the level of the calcium. Or actually in this part is the level of calcium, which triggered that we need an ultrasound first before we send him to surgery. There is a kind of a made-up rule of 3 and 3, or more than 3 rule, which is if the lesion is more than 3 centimeters in size of the parathyroid and the calcium is more than 3, then this can give you a predictive value of almost 100% that this is actually a cancer, not a benign condition. So when you have a very high calcium level, you want to see the description of this lesion, especially if you remember in the case it's actually palpable. So it's huge then. If it's parathyroid adenomas, rarely you can feel them. But if you can feel them, you need to be concerned by cancer. So this patient has a significant description that this is a cancer, and you need to know if this cancer is actually invading somewhere, or there's other, especially lymph nodes, which are considered to be suspicious before the start of the therapy or the surgery itself. Our patient has significant hypercalcemia, PTH is very high, and the scan shows to be positive, and this is actually corresponding to swelling, so we need that ultrasound. It's parathyroid cancer generally, they're indolent, they're mildly progressive pattern. They could have a recurrent disease, whether it's locally or even distally. They can invade adjacent structures. That's why we need an ultrasound. If they go to lymphatic and hematogenous metastasis, which occurs late, they can go to the lung, cervical lymph nodes. Rarely they would go to the liver. The surgical treatment would be different. That's why we need that ultrasound to tell us if this is suspicious to be cancer or not. The surgeon needs to know that, because if it's a cancer, then with end block excision of the lesion, they have to have ipsilateral thyroid lobe and isthmus to be removed completely. And even recent structures or tissues, if they are adherent to the tumor, they also need to be removed. And you need to skeletonization of the trachea, meaning clean up the trachea completely, remove the part of the soft tissues and try to clean that also, because there's a chance of recurrence. And any ipsilateral central lymph nodes also need to be dissected. So it's a major surgery compared to minimal invasive surgery, which was the choice number one. Radiation therapy is not responsive, unfortunately, to radiation therapy, and disappointing chemotherapy results in these individuals. So surgical treatment is the best situation. So that's why they need to have a good surgery done from the beginning. Question number 5. Oh, sorry, we're still number 5, but why the other choices were not correct. We said minimal invasive surgery will not be curative for these individuals. Cinacalcet can be given to only lower the PTH, but it's not required now because this patient needs a surgery. His vitamin D deficiency can be contributing to high PTH, but we cannot just give him vitamin D and keep following him. And renal ultrasound is not really required since the patient needs to go for surgery right away. Question number 6. This is a 70-year-old woman referred for the recommendation regarding osteoporosis treatment. She has no history of floor trauma fracture, and her mother had a hip fracture. Her current medications include omeprazole, atorvastatin, meloxicam, calcium 600 milligram twice daily, and cholecalciferol 800 units daily. View system negative for fever, weight loss, pain, diarrhea, hematuria. Her BMI is 18.9, abdominal examination normal, spinal curvature is normal, no kyphosis, no vertebral tenderness, no other abnormalities detected. Laboratory values, calcium and albumin, that gives her about almost 2.5, 2.6 corrected calcium, phosphate 1, creatinine normal, PTH 55 within normal range, vitamin D good, urine calcium 250 on the normal kind of no range. Urine creatinine, also the lower side, and fractional excretion of calcium is actually, we consider that to be higher than 0.1, which is the values that differentiate two diagnoses. DEXA scan showed the lumbar spine is minus 2.5, the femoral neck minus 2.4, total hip minus 2.1, and 1/3 of radius 3.5 minus. Her 10-year fracture risk is very high, 21% in the major osteoporotic fracture, and hip fracture is 10%, which is very, very high. So based on clinical history, her fracture risk, you recommend initiating teriparatide, or anybody else recommended that. After 3 weeks of treatment, she returns. She has concern that she's being fatigued, nocturia, and her serum calcium concentration is rose to 2.8. So based on this patient clinical history, which of the following is the most likely the underlying disorder that explains her current hypercalcemia? Is it sarcoidosis, familiar hypocalcemic hypercalcemia, primary hyperparathyroidism, multiple myeloma, renal cell carcinoma? Let's start the polling. Excellent. So majority said this is primary hyperparathyroidism and is actually the correct answer. So why is that? So first of all, 10-year probability of this patient with a fracture is very high. And these are some guidelines, European guidelines from ISKIO IOF back 2018. We also presented osteoporosis guidelines in Kuwait 2018, regardless of where she's from, because the risk of a fracture is different based on the population. And if you do calculation of fracts, whether she's from the UK or she's from Kuwait, her risk of a fracture is always in the red zone, meaning that her risk of a fracture is high. And these patients, when their risk of a fracture is very high, these patients needs to be on anabolic therapy first. So these are a kind of summary of all guidelines, international guidelines, which to manage osteoporosis. So patients who would have a recent fracture, multiple fractures, or a risk of a fracture is very high, like our patient hip is more than 4.5% versus ours is 10% almost. So these patients consider very high risk, and they need to be preferred to start on romosozumab or a PTH-based therapy, which are both of them are considered anabolic therapy. And this patient had that because of what's the description of her risk. But the problem is that this patient has a concurrent primary hyperparathyroidism. Why is that? It was missed that her corrected serum calcium was 2.6. Her calcium was at the upper border of normal, 2.5, with albumin 36. And PTH wasn't though elevated, but was in the upper normal range. So there's and also what's also important is that the greatest deficits, what was the cortical-rich one-third of radius, and we mentioned that in a previous question. So measurement of ionized calcium would be very advisable in this situation. It's more sensitive to detect hypercalcemia rather than total calcium and albumin level. And following initiation of teriparatide, which is another anabolic or PTH-based therapy, patient developed hypercalcemia in the context of autonomous parathyroid function that they already have. So you have PTH from an injection, a PTH from the gland itself, so that caused the hypercalcemia. So this is not PTH-independent hypercalcemia and rules out the presence of sarcoidosis and multiple myeloma. So these results are incorrect. So because these patients will have a PTH to be low, not normal. So any high calcium with a normal PTH is a primary hypercalcemia. It's a primary hyperparathyroidism until proven otherwise. Because with PTH independent, they have to have a low PTH. Otherwise, it's called a PTH dependent. Renal cell carcinoma can be associated with hypercalcemia, but that's because of the production of PTHRB related peptide. And also the PTH will also be suppressed in that condition. And her PTH is not. So although PTH and serum calcium levels could be consistent with FHH, but her 24-hour urine calcium and calculated FeNA are inconsistent because they're higher than 0.1, which for FHH, you need to have low calcium in the urine. The calcium in the urine and the FHH should be very low, and their FeNA actually is less than 0.1 in terms of value. Next question. This is a 67-year-old man hospitalized after low trauma fracture of the femoral neck 1 week ago. The fracture has been treated with total hip arthroplasty. Clinical risk factors for osteoporosis include that he's a regular alcohol intake, 3 standard drinks per day, has a low BMI. His only regular medication are vitamin D supplement, also using some thiamine and bentoperazole. Overview of symptoms: patient reported long-standing low libido, low mood, and fatigue. His post-operative pain is controlled on opioids following the surgery. His BMI is 18.9. Visual fields are normal. Eye movements are full. He has low muscle bulk, scattered spider nevi, pulmonary edema. His liver is palpable 2 centimeters below the costal margin, no ascites, and testicles are 15 mL bilaterally. These are laboratory values done post-operatively day 2. They were drawn at 8 in the morning while fasting. His AST and LT are slightly above the normal range, GGT also. Total testosterone is 1.9, which is very low. LH and FSH also on the lowest side. Prolactin is normal, slightly above normal, 28 nanograms. Vitamin D is slightly low. Serum creatinine electrolytes were normal, so that includes calcium, magnesium, phosphorus, all these things. And also renal function and other minerals are also normal. They did a repeat of total testosterone on post-operative day 4, again, 8 a.m. while fasting. It was also low, 2.3 nanomole. So which of the following is the most appropriate next step in his patient management? Would you do zoledronic acid infusion, initiate testosterone replacement, initiate anastrozole, initiate zoledronic acid infusion and testosterone replacement, whole treatment, perform pituitary MRI first? So which one you want to choose? Start polling. Okay, so majority were thinking of doing pituitary MRI and doing zoledronic acid and testosterone at the same time. And okay, so the correct answer is actually you want to give them zoledronic acid. Why is that? So again, going back to choice of therapy. So this patient is considered a high risk, not a very high risk, because he had only 1 fracture so far. And since we don't know his DEXA scan, unless his bone density is very, very low, maybe I will put him on a very high risk. But this patient is still considered as risk. Some patients or some guidelines, they would treat him with anabolic therapy. Some other guidelines would treat him with bisphosphonates. So it depends on which guidelines you're using. The problem is that with these therapies, especially the anabolic therapies, they're not really the best when you want to treat hip fractures, to reduce the risk of hip fracture, especially in someone who had the previous hip fracture. Because we know anabolic therapy, they do very well in spine densitometry. They improve the bone densitometry in the spine significantly. But when it gets to the spine, to the hip, that's when the deficiency happens. So there is still a debate whether to start anabolic or start bisphosphonates in patients who develop the hip fracture. So the zoledronic acid, we know it's a significant, its ability to significantly reduce the risk of fractures there. This comes from the Horizon trial, is able to reduce risk of fractures. You can see between 40 to 70%, hip fracture 40%, which is much higher than what anabolic therapy does. And vertebral fracture about almost 70%, non-vertebral fracture about 25%. And also, that's what makes zoledronic acid may be more attractive, is that there's a analysis done on the Horizon trial. It wasn't a primary outcome, but it was a secondary outcome, and all-cause mortality in patients who come in with hip fractures. And they were looking at this mortality, 90 days of hip repair. They were actually looking up to 36 months, and they saw about almost 30% reduction in all-cause mortality in patients who come in with a hip fracture. They were given zoledronic acid within 3 months of their repair. So that makes the zoledronic acid more interesting, especially if the patient will stay in the hospital for a longer period of time. That would be a good way of treating this patient. So this patient also has mentioned that he has non-specific symptoms like chronic alcoholism, because of chronic alcoholism and liver disease. So hypogonadism and malnutrition also can develop in these individuals. So, and his liver test shows that he could have alcoholic hepatitis. Now, gonadal studies that suggest that he does have hypogonadotropic hypogonadism, but there's multiple reasons why he could do that. First, he does have chronic alcoholism, which by itself can cause hypogonadism, whether primary or secondary. And also, he's under stress, okay, and with acute fracture, and also using opioids, which are very known to suppress pituitary function, causing low gonadotropins and also hypogonadism. So there's plenty of reasons why he could have that. So they wouldn't be appropriately at this point to do an MRI of the pituitary. Mild prolactin increases also because of many reasons. Stress can be enough reason. And also the prolactin stimulatory effect of opioids, which is there. So mild prolactin increase, you can see that in patients who are admitted with hip fractures being given opioids. We don't have why the choice is not testosterone only or testosterone and bisphosphonates. So we don't have a fracture data on testosterone treatment, unfortunately, until now. The Endocrine Society guidelines emphasize that men with high risk fracture risk, they need to be on drug therapy with a proven anti-fracture effect, regardless if they will receive testosterone treatment for hypogonadism management. So they will receive testosterone, they will not receive testosterone, you need to give them drug therapy with a proven anti-fracture effect. So that's why the choice of testosterone wasn't there. Why not giving them both at the same time? I would not give testosterone for an inpatient who come in for an acute emergency for things that are now related to his testosterone hormone. And plus, with testosterone, might increase some of the risk related to complication within the hospital, specifically talking about thrombosis and so. So it wouldn't be a drug therapy while he's inpatient. If he doesn't recover that following the discharge or following improvement of his status related to his alcoholism and opioid use, and then probably he needs to be on a longer term testosterone therapy while monitoring his liver function and not to cause further side effects. Aromatase inhibitor, they're prescribed off-label for treatment of functional hypogonadism sometimes. Why is that? Because it can decrease the estradiol negative feedback. So the aromatase inhibitor, they prevent the conversion from testosterone to estrogen. And when you cut that, you will have less estrogen, pushes up the LH and FSH trigger and start to stimulate testosterone. It hasn't really proven in this situation to use. Plus, he's an inpatient, not the best way. And definitely, this is not a drug therapy to treat osteoporosis in this condition. Next question. 43-year-old woman presents for follow-up of hypocalcemia due to hypoparathyroidism that occurred due to thyroidectomy for a thyroid lymphoma 3 years ago. Despite adherence to treatment with 4 grams of elemental calcium daily, divided doses, calcitriol 1 microgram daily, she continued to have symptoms of hypocalcemia, mild to moderate. She tried hydrochlorothiazide in the past, but caused hypokalemia despite taking potassium supplements. So she stopped it and didn't really do much on the calcium level. And she was started on recombinant human PTH 184 injection, which was a licensed drug therapy for patients with hypoparathyroidism. She had been doing well on the dosage of 75 microgram daily, with significant reduction of her calcium supplements. So she required much less. So only 2 grams a day of calcium and only half a microgram of calcitriol. However, she stated that's been unable to get the recombinant human PTH 184 because unfortunately there was a recall on this drug a few years ago, and it's still now a lot of places is not really available. So now her symptoms started to come back again, her hypocalcemia symptoms that she had it before she started the therapy. She has a positive tryphotic sign, neck examination, just a surgical scar, otherwise is normal. This is her result showing hypocalcemia significantly, phosphate is elevated, creatinine normal, PTH is very low with that level of low calcium, telling you that this patient truly has a hypoparathyroidism. And vitamin D within normal range, magnesium also within normal range. So which of the following is the most appropriate next step in managing this patient hypocalcemia? Recommend no changes to her medications, go up on the calcium to 4 grams, or go up on the calcitriol to 1 mic a day, or increase both calcium and calcitriol 4 grams to 2 microgram daily of calcitriol, or start once daily teriparatide injection. Let's start the poll. Okay, so 45% answered the correct dose, which definitely you need to increase both the calcium and the calcitriol. You cannot do calcium alone, and you cannot do calcitriol. She needs more calcium and more calcitriol definitely. So that would be the right choice to do. So these are the causes of hypoparathyroidism. By far, the most common cause is postoperatively, parathyroidectomy or thyroidectomy. That would be the most important. There's other multiple reasons. We're not going to go deep into them. It often occurs, the post-surgical hypopara, occurs after thyroid, parathyroid, or any radical neck surgery and head and neck surgery. It might be transient, like days or weeks or even months, or could be permanent. The transient is 20% after thyroid cancer surgery. There could be transient hypocalcemia. The permanent is actually very low after total thyroidectomy, up to 30%. And that also depends on the surgery and the surgeons and how this patient is being performed, or the surgery, how it's being performed. So if the patient is asymptomatic, but the patient level of calcium is less than 1.9, then you definitely need infusion, as we said in a previous question. And also at the same time, start them on calcium and activated form of vitamin D. If they're asymptomatic and the calcium level is between 1.9 to 2.2, it's fine to start them on oral calcium and activated form of vitamin D. And always, always correct magnesium, because magnesium deficiency can create PTH resistant and not able to correct the whole calcium. These are the conventional therapies for hypoparathyroidism. So you have calcium carbonate or calcium citrates. The good thing about calcium citrate is that you can use it. It's preferred in patients who have PPIs. You don't have to have acidic stomach to digest citrate, but with carbonate, you need an acidic stomach. But the good thing about carbonate is it actually gives you the much larger elemental calcium out of a calcium supplement comes from the carbonate. That's why it's the most one used. If you use citrate, you need much more pills to get the same elemental calcium amount compared to carbonate. D3 or D2, which one to use? Majority of the uses D3, but you can also use D2 in mild to larger dose, depends on the deficiency you have. Calcitriol or alpha-calcidol, both of them, you can use them to treat or as an activated form of vitamin D. Thiazide also, you can use them as augmentation of the therapy. But when you treat hypoparathyroidism, the goal is to try to improve symptoms. You want to get the calcium level between a low normal range, which is 2 to 2.1. And definitely you want to do that because you don't want to cause iatrogenic hypercalciuria, because you don't want the calcium level to be more than 250 or more than 300 milligrams per day. If that situation happens, maybe you want to use thiazide diuretics to lower that calcium in the urine. Because if you do that, then you can develop kidney stones and kidney impairments. Now, there was the NetPara, which was a recombinant PTH 184, which considers the whole sequence of the parathyroid hormone. It was FDA approved for treatment of chronic hypoparathyroidism. back in 2015, and indicated for patients who are on conventional therapy, but they're still not able to get to the right target. And you need to have them sufficiently on calcium supplements and vitamin D supplements before you start them on this therapy. But unfortunately, just before COVID, there was a recall on this drug, and I believe it's still not available in the majority of places. So this patient, when they discontinue her therapy, she needs to go back on this kind of similar higher dose conventional therapy to improve her calcium, low calcium. Now, teriparatide, which is only the active form of PTH, which is the sequence of 134, is not FDA approved for treatment of hypoparathyroidism, but used as an off-label therapy. And there are some studies show that to be effective, but the problem is that it's a short-acting, and you need to have it dosed like 2 or 3 times a day to raise the serum calcium level because of its short half-life. There are emerging therapies. There is something called TransCon PTH, which is similar to teriparatide, but attached to a molecule that makes it as a long-acting drug. And there's the other long-acting PTH analogs. There's oral PTH molecules. And there's also calcitolytics, which are antagonists to the calcium sensing receptor, which also helps to improve the low calcium level. Next question. 42-year-old woman seeks evaluation of hypophosphatemia. She reports long-standing fatigue, muscle weakness, and bone and joint pain, requiring opioid medication for pain control. She also reports dental problems as a child. Despite treatment with phosphate and vitamin D supplementation, she continues to have mild to moderate symptoms. She's currently taking calcitriol 1 microgram twice daily. She has been adherent to her regimen of supplements also. She has 2 recent low trauma tibial insufficiency fractures. She reports no nausea, vomiting, and diarrhea. She has 2 daughters, with also being evaluated for low phosphate levels. Her height is 152, and she has a mild bowing of her lower extremities. Her examination findings is unremarkable. Calcium and albumin, as you can see these levels. Phosphate is low, creatinine is normal, PTH is slightly elevated, 75. Vitamin D level is normal, and her 125 vitamin D is low. Which of the following is the most appropriate next step in the management of this patient's hypophosphatemia? Increase her oral phosphates, increase her calcitriol dose, start teriparatide, switch to borosumab therapy, treat with intravenous phosphate. Let's start the polling. Vast majority answered the correct answer, which is switching to borosumab therapy. That's quite good. Okay, so this patient has an X-linked hypophosphatemia. The gene responsible for that is the fixed gene. It's a phosphate regulating end plates on the X chromosome, so expressed predominantly on bone and also on the teeth. It's the inactivating pathogen variant in the fixed gene causes the X-linked hypophosphatemia by increasing the production of the FGF23, which is a phosphatonin which makes the patient do not really concentrate and to contain the phosphate in their body. They will waste it outside their body. It's an X-linked dominant pattern of inheritance. Features in adults that they could have fatigue, muscle weakness, stiffness, bone pain, and gait abnormalities. Findings, they could have leg deformities, teeth defects, osteomalacia, short stature, and also osteoarthritis. The findings, you will have low phosphate, a low activated form of vitamin D. Why? Because with this, they will have decreased expression of the 1-alpha hydroxylase enzyme, which converts the 25 to 125 vitamin D. And also, they have also increased catabolism of the active form of vitamin D. That's why their levels will be also low. It's currently, the current treatment is giving them phosphate and active vitamin D. Also, cinacalcin can be used as an off-label therapy to normalize the PTH. And adults adult patients with X-linked hypophosphatemia, the goals of therapy, you want to get their symptoms improved, you want to reduce the extent of osteomalacia that they have, and you want to improve the fracture healing that they are prone to develop. These therapies, when we use phosphate, vitamin D...
Dr. Thamer, you have 5 minutes.
Sure, thank you. So the treatment plan with this therapy, you will go into some complications like hypercalcemia, hypercalciuria, kidney stones, and also hyperparathyroidism, either a secondary, or if that continues for a very long time, it will convert to a tertiary when you have to develop then a surgery to remove the parathyroids in these individuals. So if they continue as a secondary hyperparathyroidism in this situation. Peroxizumab is a monoclonal antibody to the FGF23. So it binds to it, blocks its action. So these patients will have in red, these are placebo. These are in blue, patients using peroxizumab, increasing the phosphate level. Fracture healing with peroxizumab. This is the percent of baseline of fracture healing is actually better at week 12, at week 24. And also the cortical part of the fractures is actually improving after treatment with peroxizumab. So there was no serious side effects associated with this therapy. It's recommended who cannot achieve a good control on conventional therapy, including adults who are symptomatic or have fractures. For adults, peroxizumab is administered subcutaneous injection every 4 weeks, and dose can be changed according to their blood phosphate level. The patient calcium level is already high normal. So if you go up on the calcitriol, it would not be appropriate because it's already in the high normal range. And increasing oral phosphates would not be the best option because the patient is already has evidence of pre-existing secondary hyperparathyroidism. And if you do that, you will even make it worse. The IV phosphate can be reserved for patients with severe symptoms. It's very, very low phosphate, less than 0.3. And there's no role of teriparatide in this condition. Let's do one more question. Maybe this will take like 5 minutes, so it's okay to just take 1 or 2 minutes extra from the time. 28-year-old man preferred for evaluation of hypercalcemia. He has had multiple episodes of kidney stones in the last 4 weeks, a year, sorry. Dietary calcium, 600 milligram daily. He does not take any calcium, vitamin D supplements, just by diet. Has no history of fragility, fracture, or thyroid disease. He has an older brother who was diagnosed with peptic ulcer disease. So calcium level, as you see, is high. Phosphate level in the lower level. Creatinine is normal. PTH elevated. Vitamin D slightly low. Urine calcium is elevated. So probably easy guess. But what's the pathogenic variant in which of the following genes is most likely explains his clinical presentation? Let's start the polling. Should be an easy question, and majority said correct is MEN1. Okay, so we'll see why is that. So he has hypercalcemia, hyperparathyroidism, hypercalciuria, and history of kidney stone. So private hyperparathyroidism, very clear. Genetic testing required because he's young. So any patient younger than the age of 30 with hyperparathyroidism, you need to do genetic testing. Patient with a family history of a primary hyperparathyroidism, you need to do one. Or a patient with a clinical finding suspicious for a familial syndrome, like I said, so like an MEN, like his brother has so much of a condition causing acidosis in the stomach. Patients with multiglandular disease, like parathyroid cancer or typical adenoma, these are patients required to be genetic testing. So this patient has MEN1. So MEN1, it's composed of pituitary adenoma, parathyroid hyperplasia, pancreatic tumor. With hyperparathyroidism, it's more common to be MEN1 compared to MEN2A. Only about up to 25% of patients would have parathyroid hyperplasia and hyperparathyroidism. Both of them are MEN1 and 2A are autosomal dominant disorders, and they occur in different population, and we've shown you the glands that they could affect. The Cas9 gene, it's encodes the calcium sensing receptor and expressed in the multiple tissues, including the parathyroid gland and also the kidney. So if you have a loss of function in the Cas9 gene, you will cause a familiar hypocalcemic hypercalcemia, which is autosomal dominant. You can have mild hypercalcemia, but not severe hypercalcemia, and you could have a normal PTH in that situation. Few of them would have a mild elevated PTH, but majority will have a normal PTH. If you have a gain of function in that gene, it will cause an autosomal dominant hypocalcemia type 1, which is a very rare form of hypocalcemia. Major features that distinguishes the familiar hypocalcemic familiar hypocalciuric hypercalcemia from primary hyperparathyroidism is that with FHH, you will have low urinary calcium excretion, and the calcium to creatinine ratio is actually going to be very low. Hypercalcemia could be at younger age, even at childhood, and a family history you will have of asymptomatic hypercalcemia if you test these individuals. CDC73 gene is a protein called parafibromin. This is called as a tumor suppressor gene. So inactivating this gene can cause hyperparathyroidism Joe tumor syndrome, which is a favorite topic for board questions in the American boards, I believe. We don't see it here, very rare. It's a condition characterized by tumors in the jaw and the parathyroid gland. and increase the risk of parathyroid cancer. DDR gene is coded for vitamin D receptor gene, and inactivating this gene can lead to vitamin D resistance, but have no role in the parathyroid gland tumor genesis. So with that, we can end the presentation. Thank you so much.
Thank you, Dr. Thamer. You are really give overview and informative talk about parathyroid and calcium metabolism. We have few questions without any delay. The first question, when to give IV calcium gluconate 11 gram in 1 liter normal saline at rate of 50 ml per hour?
When to give?
Yes.
Well, I mean, you don't want to use very high doses initially, okay? So you want to do small boluses of calcium gluconate to treat severe or symptomatic hypocalcemia. And we said that, you know, IV calcium can be given in patients with symptoms, even though they have a mild hypocalcemia, but since they have symptoms, so that warrants IV calcium. Or if they have a severe hypocalcemia, especially with the corrected calcium is less than 1.9, 1.8, that would be an absolute indication for IV calcium.
I think, Dr. Thamer, it depends on level of calcium. Usually we dilute 10 ampules of calcium gluconate in 1 liter, and then we'll give 1 ml per kg per hour.
Yes.
It depends on the level of the calcium.
Yeah. So it's exactly what I said in the answers, that we gave a bolus first, which was 150 milligram, and then we started an infusion, which is 1 gram per hour in that individual. So that's one way of doing it. So there's definitely multiple ways of how to count the infusion rate, but eventually you want to give appropriate dose that is not excessive to cause any side effects.
So it is not fixed 50 ml per hour, depends on the weight of the patient.
Exactly.
The second question, how cholecalciferol will work in Instagram disease? It will not be converted. Why not 125 form, which is calcitriol? I think this you mentioned this in one of your questions.
Yeah, so you want to have calcitriol on all these individuals with end-stage renal disease because of multiple factors, you know, improving the creatinine D, the effect of vitamin D. And I understand that there's always been a debate whether to use 25-hydroxyvitamin D in end-stage renal disease. But what we believe is that with 25-hydroxyvitamin D, there is improvement in the vitamin D or in bone matrix. And we think that there's a direct effect on 25 at that point. And also, it probably could have another effect on the GI absorption of calcium other than what the 125 could improve. We definitely still exploring multiple effects of vitamin D on not only just a kidney disease or a bone disease, but actually multiple other health-related conditions. And we've seen vitamin D improve some of things related to immunity, other organ functions. And having a low vitamin D, if you have a low total vitamin D, is not really an ideal situation that you want to abandon and you want to treat.
Okay, thank you, Dr. Thamer. The third question, after renal transplant, will parathyroid hormone normalize? And when, if it is?
It should normalize. It depends then on other factors too, but it depends on even if the parathyroid actually reached a point of autonomous function. Because keep in mind, if they moved on to tertiary where they develop an autonomic function, even if you start them on renal replacement therapy, whether with a transplant or put them on dialysis, they will still make a lot of parathyroid. And patients who go for renal transplant, they want to make sure that they don't have autonomous function of the parathyroid. And some of them can be subjected to parathyroidectomy even before going into renal transplant, because it might not cure the hyperparathyroidism at that point. So you want to make sure there's no autonomous function of the parathyroid before you do a transplant. And if it's the parathyroid or hyperparathyroidism that was before the transplant is only a secondary, not a tertiary, it should improve after the transplant. When it takes time, it probably weeks because of the half-life of the PTH, which is not too long, but not too short. But within weeks, it should normalize. As the creatinine and GFR improves, creatinine comes down, the PTH also will improve. And also the direct effect of phosphorus when it also declines and improves.
The next question, maybe this is it is a topic. Could you briefly highlight us about normocalcemic hyperparathyroidism?
So it's a common situation. We see it because we investigate a lot and we do a lot of random tests unnecessarily, unfortunately. So then a lot of times you will find a high PTH with a normal calcium just because there was no reason to order a PTH, to be honest, or even doing it as an evaluation for anything else. So normal calcemic hyperparathyroidism is a state of autonomous function of the parathyroid, where they could have either hyperplasia or adenoma. But the degree of the PTH that is elevated was not enough to cause a significant bone resorption and then release of calcium from the bone, not causing hypercalcemia. But it could have detrimental effect on bone as an organ and causing low bone density throughout the time. So if you're sure about this patient does have normal calcemic hyperparathyroidism and his high PTH is not because of a secondary causes, like renal insufficiency, vitamin D deficiency, whatever the cause, then it's optimally that you need to follow this patient for bone health, try to improve and optimize as much as you can and follow it to see if it deteriorates or not. You want to make sure that these patients don't develop in the future any kidney stones or nephrocalcinosis. But there is no interference within surgical option unless actually some sort of a complication develops. The rule of age doesn't really apply here. The rule of high calcium doesn't apply here because they're normal calcemic.
The next question, is there a rule of forearm BMD in diagnostic osteoporosis apart from cases of hyperparathyroidism?
So the forearm BMD has been integrated in some of the guidelines as a diagnosis of osteoporosis. And here it depends on guidelines. So generally our guidelines, which depends on T-score to diagnose osteoporosis. There are other guidelines depends on FRAX, which is estimating the risk for fracture to determine if these patients have osteoporosis and they need on therapy. So guidelines which stress on using DEXA scans, usually are US-based guidelines. So they will tell you minus 2.5 BMD or T-scores in any location of the spine, hip including total hip or femur neck, and the forearm. So anytime it's minus 2.5 or lower, indication for treatment for osteoporosis. FRAX-based, which estimates risk of fracture and then decide on treatment, will take into account the BMD of the femoral neck, will not take into account the T-score of the forearm, only the femur neck, plus the other additional risk factors of this patient to decide if the risk is elevated and then this patient would require to be on therapy or not.
The next question, when can we start osteoporosis treatment after fracture?
You can start immediately after. There was always a concern from orthopedics about whether bisphosphonate can affect the bone healing, but multiple trials has been tested and showed no effects, no detrimental effects. So it's safe to give bisphosphonates following the repair of the fracture that happens, especially if it's a hip, for example. Even including if you decide on giving anabolic or even decide on giving bisphosphonates is fine. You want to make sure that you want to eliminate or investigate secondary causes of the fracture itself. So you don't want to be put in a situation where the cause of the fracture of this patient is actually a primary hyperparathyroidism, for example, and you missed it and you started him on a bisphosphonate or even anabolic therapy, which is worse, was one of the cases as an example.
We will use active vitamin D for acute hypocalcemia.
You need to have active vitamin D at the treatment of hypocalcemia, yes, especially if this hypocalcemia is not very short temporary situation, but it's going to continue for some time. Yes, and whatever the cause is, whether it's nutritional, hypoparathyroidism, any cause of hypocalcemia, you need to, because again, if it's a PTH-dependent hypocalcemia, or even if it's not, you want something which resembles the action of PTH. And 125 vitamin D, activated form of vitamin D, is the closest we have to the action of PTH on the body.
Another question, how to differentiate by looking to the labs between different types. He said as the labs really confusing in vitamin D deficient versus vitamin D resistance versus tumor-induced osteomalacia and X-linked hypophosphatemia.
a very long question. I'm not sure how to even describe all these changes, but yeah, I'm sure it's. I mean, I presented at least osteomalacia and end-stage renal disease. I presented X-linked hypophosphatemia, and you've seen the changes. With end-stage renal disease, you will have high phosphorus, definitely. X-linked hypophosphatemia, you will have low phosphate. What else? Osteomalacia, you will have low minerals. Also low vitamin D and calcium with osteomalacia. Vitamin D resistance, also you will have hypocalcemia. And whenever you give vitamin D, it will not be sufficient to contribute or to treat the hypocalcemia in these patients. So some of them based on laboratory values, and some of them after treatment, you will not find don't find an improvement, especially if you're talking about vitamin D deficiency, resistance.
And some genetic, by using genetic study.
Oh yeah, I mean, if you reach the point that you're suspecting that could be a genetic syndrome, yeah, definitely, you need to have genetic testing. But sometimes you don't reach that point unless you do further investigation and even do a trial of conventional therapy. After that, you find out that this patient acting or behaving in a different scenario other than just a regular osteomalacia because of a chronic medical condition or severe malabsorption.
Okay, another question. 65-year-old lady previously told to have osteopenia and different denosumab that she took for only 1 year and then stopped by herself 1 year back. Presenting now because her latest PMD showed T-score hip and lumbar osteopenia, but T-score minus 2.8. What to do?
So initially, what I would do for someone who's 65 and had a bone density test, regardless of the T-score, okay? If it's minus 2.8, minus 1, regardless, I would do a FRAX. Estimate her risk of a fracture based on her clinical scenario, ethnicity, I would just choose the country model. And if the FRAX tells me that her risk of a fracture is above the lower assessment threshold, which is the range which you would require to do a screening DEXA, then I will do a DEXA scan on her. If I do a DEXA scan, I will use the BMD of the femur neck, integrated within the FRAX calculation again with the known risk factors. And then I will look at the major osteoporotic fracture risk for fractures. And then I will see if it's above the intervention threshold or not, based on the country model that I'm choosing. If she's above the intervention threshold, I will start treatment. If she's below the intervention threshold, I will not start treatment. Again, regardless of the T-score of the spine, because integration of the clinical information and the femur neck BMD, we think this is the direction of how to manage osteoporosis.
Okay, can we use denosumab or bisphosphonate in primary hyperbara if the calcium is high till the cinacalcet work?
Yes, you can, but they're treatment to try to lower calcium, not lower PTH. So you can save them or you can protect them from the very high calcium level, but you need to have eventually some sort of a curative management for these individuals. So temporarily we can use it for severe hypercalcemia, pending to get further evaluation and surgery. Definitely we can give them xylendronic acid or brimidronic acid or even denosumab. But that would be a temporary situation until we make sure that more legitimate therapy is actually there. And we probably don't need to give them if the hypercalcemia is very minimal. So let's say up to 2.8, 2.9, or then I don't really need to give them these kind of therapies unless they're severe hypercalcemic. So something 2.9 and higher, then definitely I need to give them.
The last question. What is the vitamin D dose for gastric bypass patient and when it should be started after surgery?
So I think there is some recommendation in the bariatric fields of what kind of minerals and vitamins needs to be given, and definitely vitamin D is one of them. So you need to have vitamin D tested done before the surgery, before the bariatric surgery. If they have a deficiency, you need to correct it definitely first, and try to keep them on maintenance doses before even after the surgery. So the maintenance for vitamin D is between 1 to 2,000 a day, to national units a daily. For bariatrics, you might reach even higher. So I would keep them on 2,000 at least of vitamin D daily, or corresponding weekly or even less frequently. But I should get vitamin D before surgery and get it corrected before that. What if the patient hasn't done vitamin D before the surgery and only the first test was after the bariatric? Then I would treat him according to what I have. So if I have a large doses that I can do daily, I can do 5,000 daily. That would be a safe dose to be considered as a daily dose. I can do 50,000 in a week. That also can be considered as a safe dose.
The last question, maybe for a few seconds. Mild primary hyperpara, but severe osteoporosis, T-score almost -4. Could I use for-tube patient-review surgery?
No, you can't. It's contraindicated. Patient has a primary hyperparathyroidism. You should not give him anything that resembles a PTH. It's contraindicated.
Okay, thank you very much, Dr. Thamer.
Welcome.
Thank
you so much.
Good evening, everyone. This is Dr. Nasreen Al Sayed, endocrinologist and lipidologist from Bahrain. I will be chairing the last session of this interesting endocrine review course. And this session is going to be on obesity, a very interesting and widely growing field. And it gives me a great pleasure to introduce Dr. Nasreen Al Faris tonight. And she's going to be giving us a nice questions on obesity. Dr. Al Faris, she's an endocrinologist who specializes in obesity medicine, in addition to her experience in endocrinology, diabetes, and metabolism. Dr. Nasreen, clinical and research experience expands to cover transdisciplinary treatment of obesity and its complications, weight regain after bariatric surgery, and patients who fail to lose adequate weight after bariatric surgery. Dr. Al Faris also serves on the executive board of the International Federation for Surgery for Obesity, IFSO, Integrated Health Section, as the vice chair of the Professional Guidelines Committee. Academically, Dr. Al Faris served as a faculty member at the Blackburn course in obesity medicine at Harvard Medical School and currently at the Boston Obesity Medicine course, helping to educate healthcare professionals about obesity management. She is also the founder and program director of the Obesity Medicine Fellowship in Saudi Arabia, the first and only accredited program in the region. During her career, Dr. Al Faris has received multiple awards, including the Roberto Franco Intern of the Year Award and the Robert D. Edgar Award of Outstanding Research by an Endocrine Fellow and Master Integrated Health Award from IFSO. She is an international speaker in the field of obesity medicine and has authored papers and editorials in many journals. Dr. Al Faris received her medical degree from King Saud University in Riyadh, and before pursuing Masters of Public Health degree at the Ghazal School of Medicine, she completed her residency in internal medicine at Case Western Reserve University and Endocrine Diabetes Fellowship at the University of Pennsylvania, where she later joined the Center for Weight and Eating Disorders. Dr. Al Faris is the past chair of the IFSO MENA Integrated Health Section. She is also an active member of the World Obesity Federation. Clinically, Dr. Al Faris works at King Fahd Medical City Obesity Endocrine Metabolism Center as a consultant in endocrinology, diabetes, metabolism, and obesity. And with this, it gives me great pleasure to introduce her. And I wish you very enjoyable questions for the next coming 45 minutes. Dr. Al Faris, the platform is yours.
First of all, thank you for the very kind and extensive introduction, Doctora. I'm trying to start to share my slides. I'm hoping you guys can see them. I don't think you still can see them, but let me give this another try with sharing my screen. And I think there we go. So I'm going to start with this question. So this is a 45-year-old man with class 2 obesity. And And he has a BMI of 38. He presents to your clinic. He tells you that he has been trying to go on an energy restrictive diet since he enrolled at college. He says, I've tried everything. I lose about 10 to 20 kilograms. Then I fall off the wagon and fall back into my old habits and regain all the weight and even regain a little bit more. He's tired and no longer wants to yo-yo diet. The abnormalities in his lab tests include an LDL of 170, an HDL of 48 milligram per deciliter, a hemoglobin A1C of 6%, and no other abnormalities were detected in his labs. He's asking for your help. He's determined that he will stick to his diet now because he does not want to develop diabetes. Since it seemed that this patient has responded previously to lifestyle interventions, what do you think the reason behind his recurring failure to maintain his weight loss? And how does this affect your future plans for treatment? So these are the answers. A would be energy restriction will cause increases in appetite and hunger through changes in the gut peptide, ghrelin, PYY, CCK, amylin, GLP-1. His dieting will not have any impact on his energy expenditure or stress response. B, energy restriction will cause increases in appetite and hunger through changes in the gut peptide, the same gut peptide, but his dieting will also have an impact on his energy expenditure and stress response. C, the level of gut peptide, the ghrelin, the PPY, the CCK, the amylin are only affected during the period of the diet, but those effects are not long lasting and the hormone levels go back to their baseline levels as soon as the diet is stopped. And D, the level of gut peptides are only affected during the period of dieting. Those effects are not long, this is wrong, but those effects are long lasting and the hormone levels go back to their baseline levels a few months after the diet is stopped. So I think, so what is the right answer? Is it A, B, C, or D? Those who have worked with me previously in clinic should get this. So B, energy expenditure will be affected and his dieting will have an impact on his energy and stress response. So let us try to do this. I wonder why. Okay, there we go. So the answer is actually B. It will have an impact on his energy expenditure and stress response. In addition to this, it's not only that these changes in gut peptide are actually going to last. And the reason behind that is fat mass is regulated by a complex system. So when you think about fat mass or the amount of fat that we have in our bodies, you should think about it as blood volume or liver volume. So when we tell people, for instance, to go and donate blood, we do not tell them that you're going to become anemic after that. When we tell them to donate part of their liver, we do not tell them that you are going to have less mass of the liver. We tell them that your blood is going to just get back to whatever mass it was or whatever volume it was. And with your liver, it probably will not grow into the same shape, but it's going to maintain its mass. And that's the same thing happens with fat cells. So what happens with fat cells is that no matter if people try to lose weight in whatever weight it is, especially with energy restriction, the body will try to defend that fat mass and will raise the weight by changing hunger hormones and satiety hormones and changing energy expenditure to maintain that fat mass. So everybody has a certain fat mass set point, and then we have all these microenvironmental factors that goes on with us, which is the abnormal dietary constituents, unhealthy muscles, sleep deprivation, stress, disrupted circadian rhythm, and weight gain inducing medication that we go throughout our lifetime. And as the years go by, with you going through these, what ends up happening is that you end up basically elevating your fat mass set point, and that by definition is the disease of obesity. So, and I'm not going to go a lot through this. This is just, all the, because I'm sure that, almost everybody knows about this. You have down here the ghrelin, which is your hunger hormone, and then you have your PYY, insulin, leptins, and GLP-1s. And these all go through the two pathways in the arcuate nucleus. the POMC-CART pathway, which is your basically anorexigenic pathway, and then your agouti-related protein pathway, which is your orexigenic pathway, and then they go to the higher level neurons with MC4 in the paraventricular nucleus, and that's how basically that's the simplified basic pathway for obesity and weight gain. So what happens when you actually diet? So this is just showing how people really vary in their fat mass set points. So this is, for instance, if you can look at the far left, this is someone whose BMI throughout their life probably will range between 20 and 24. If you look at the last person here down, you can see that their BMI will range between throughout their lifetime 24 and 55. So people really, there's a variation in their response where some people have a very, very tight fat mass set point where they might gain plus or minus 5 to 10 kilograms, and others with a wider fat mass set point that can actually change as we develop, and women get pregnant, for instance, men age, people go through stresses throughout their lives. And unfortunately, when you start dieting and restrictive dieting, what happens is that, like what the person in the question was doing, so this was his, his level, his fat mass set point. So this was him at baseline. After, if he does a healthy lifestyle, he goes here, not dieting. And then when he regains, he probably ends here in the middle. So he'll regain a little bit. But what happens when he actually energy restricts is that he will leave that fat mass set point and just kind of overshoot and lose a lot of weight. And the body reacts in a very bad way when you do that, where it actually causes rebound weight gain and moves that fat mass set point a little bit further. And that's why people will tell you that I've been, dieting for the past 10 years. But what I've noticed is that I weigh now more than I weighed before my first diet. And it's because of this restrictive dieting, because a lot of what you see from nutritionists and primary care physicians is what they're telling their patients is to go and cut 500 kilocalories from their diet. And this is really what they're doing, is that they're making their disease more resistant and just moving their fat mass set point to a worse place. So if you can see what's happening with him again, going through another, doing the diet again, he's already moved his fat mass set point or his zone or variability. And he does another diet because he's trying to lose weight. He never loses as much weight as his first diet. And again, he overshoots, and then he yo-yo rebounds. And as this happens over the years, this is just what's happening with him. So do we have any data that actually backs up everything that I'm saying? So yes, we do. So this is a very famous paper by Priya Simithran. And what she did, she had individuals here go on a 10-week long restrictive diet. And before the diet, she did ghrelin levels, she did amylin levels, CCK, and measured it right here, and then measured it again at the end of the 10 weeks of dieting. And then she told everyone to just go home, live their lives, and just come back a year later. So there was no dieting between week 10, as you can see here, week 62. And what happened is that people obviously regained the weight. And at the end of the year, she measured their hormones again. And this is what she saw. So you can see 3 colors in each graph here. And what you see here, black is the baseline. Blue is at week 10 at the end of the diet. And then red is at week 62 or at the end of the year. And you can see their ghrelin level were pretty low or normal just before dieting. Once they started dieting, what happened was that at the end of the diet, their ghrelin levels went up, which means that they get hungrier because ghrelin is the hunger hormone. Even after stopping the diet for a full year, their ghrelin levels never came back to their baseline. And this is after, again, restrictive dieting, or what we call caloric restriction. Their satiety hormones followed a very similar pattern, where at baseline, you can see the PYY, the CCK, and the amylin satiety hormones that were normal. They were a little bit, they're, just in a normal level at baseline. But after dieting, after the blue line here, you can see that their satiety hormones actually went down. But 1 year, they even got worse with their satiety hormones. That's with the PYY. You can see with amylin, they never went back to normal again at 1 year. And with the CCK, they followed the same pattern. So basically, when you restrict your patients' calories, what you're doing is that on the long run, you're making them hungrier and you're making them less full when they eat. So you're making their problem worse. When you look at energy expenditure, so this was done by Rudy Leibel and his group in Colombia. And what they did, they had people come in with their baseline weight. And that's why here you see the initial weight with no graph. And then they had a group of people gain 10%. And then they measured energy expenditure. And what they saw is as you gain the weight, your energy expenditure goes up to basically maintain a certain fat mass set point. So because your body wants to maintain that certain zone, it doesn't like going up and down. And when he had individuals lose 10% of their weight or 20% of their weight, again, by energy restriction, what happens is that as they lost weight, their energy expenditure, their total energy expenditure went down. So basically they burned less. And after dieting, unfortunately, their total energy expenditure never went back to normal. So they tended to still burn less even after that small period of dieting. So this is what happens when you caloric restrict. So let's move to the next question. So the next question is this 23-year-old female patient with hypercortisolism diagnosed in infancy on hydrocortisone replacement. She's transferring to your clinic for another endocrinologist. She has class 3 obesity. Her BMI is 42. Her history, it seems that she had childhood onset obesity with her parents reporting hyperphagia. She also has a history of hypoglycemia and hyperbilirubinemia and cholestasis when she was born in the neonatal period. On exam, she has general adiposity. Her skin is pale and she has reddish hair. And when you hear the word reddish hair, you should know what this is. And she has no other positive findings. Her parents ask you, why is it that they cannot control her eating? You discuss with them the orexigenic and anorexigenic pathways that I just showed you guys in the brain. And you state that her defect is most likely related to what? So here are the answers. A genetic defect leading to activation of the orexigenic pathway. Or is it B, receptor defects in the paraventricular nucleus of the hypothalamus leading to loss of function of the anorexigenic pathway? Or C, receptor defects in the paraventricular nucleus of the hypothalamus leading to activation of the orexigenic pathway? Or D, receptor defects in the arcuate nucleus of the hypothalamus leading to loss of functioning of the anorexigenic pathway? And E, receptor defects in the arcuate nucleus of the hypothalamus leading to activation of the orexigenic pathway. So here are the answers, and they'll put in the poll now to see which one you choose. This is kind of a two-step question where you have to figure out what they have first and where the defect is from what they have. So the poll is closed, and I can see that there is 32% for D, I think, and E27. So it's really a mix. So let's see what the answer is. And again, this doesn't work. Oh, there we go. So receptor defects in the paraventricular nucleus of the hypothalamus leading to loss of function of an anorexigenic pathway. So it seems like this person has really MC4 abnormality. And again, I'm showing this. Remember here, this is the paraventricular nucleus. We have two pathways, as I said. POMC, remember, that's the anorexigenic pathway, which is the pathway that tells you not to eat. The agouti-related pathway is the orexogenic pathway, which is the pathway that tells you to eat. These are down here in the arcuate nucleus. As soon as you go up to the paraventricular nucleus, that's where you found the MC4, and that's where the MC4 receptor is affected. And those are the reasons. And here's the CRH. That's the reason you have those individuals with pale skin and reddish hair. That's why it's a telltale where the defect is. So as I said, it's a two-step basically, it's just a two-step question where you have to figure out what they have. So it's an MC4 receptor defect and where that is. And we actually have a treatment for this, and that's why I included this here. So this is an FDA-approved treatment. We have setmelanotide that is used in these patients, and you can see here a couple of patients that were on setmelanotide. Once you give them these injections, they start losing about 3 to 4 kilos a week. These are 2 patients. He said these were stopped because of the benefit. And now I don't think it's not. So the drug now is also FDA-approved for Bardet-Biedl syndrome. And it is actually available here in our region, in the GCC countries, if you want to give it to your patients. So remember, patients with early onset obesity, this is a very classic, this is a real patient, but you can find even with partial abnormalities in MC4, these patients actually do respond. Always think about patients with obesity before the age of 10 years. Hyperphagia, what is going on? Probably there's a genetic cause. Probably this is actually monogenic obesity that's causing this. So next question. This is a 45-year-old patient with type 2 diabetes. He's diagnosed 6 years ago. He's in your office seeking consultation for metabolic surgery for his diabetes. He was on metformin in the past and gliclazide for the first 3 years following his diagnosis, but he was shifted later to insulin treatment. Is currently on insulin glargine, 20 units every night, along with metformin 1,000 milligrams twice daily, and liraglutide 1.8 milligrams daily. His hemoglobin A1C is 6.2%, and his BMI is 45%. His other medications only include lisinopril and atorvastatin. His ALT is 35, and his AST is 30. So based on this metabolic profile, what would you tell him regarding metabolic surgery? Because remember, you are seeing these patients first. You're seeing them supposedly before the surgeon does. So here are the answers. Answer A, BMI is really not a predictor of diabetes remission in patients with type 2 diabetes who undergo bariatric surgery. Therefore, this patient with a controlled hemoglobin A1C would not have an added metabolic benefit from surgery. B, the ADA actually recommends metabolic surgery as a treatment of type 2 diabetes in appropriate surgical candidates with BMI either equal or more than 40 kilograms per meter square, regardless of the level of glycemic control or complexity of glucose-lowering regimens. Therefore, this patient is a good candidate for metabolic surgery. C, this patient has good diabetes control with a good regimen, and is on liraglutide, which will help with both his blood glucose control and his weight. Therefore, metabolic surgery would not be recommended at a later stage. Maybe you could recommend it at a later stage, but not now. And D, that Stampede trial, 5-year data shows relapse of diabetes at 5 years with sleeve gastrectomy, and the Mingroni trials show relapse of diabetes at 5 years with Roux-en-Y gastric bypass, and in few patients who underwent even biliopancreatic diversion. So everybody relapses. The diabetes just keeps on relapsing. Therefore, although metabolic surgery is an option for this patient, he may not benefit freely from the procedure on the long term. And E, both the duration of his diabetes and insulin use are predictor of remission of type 2 diabetes. And since this patient has diabetes for more than 5 years and is on insulin, he may not benefit from metabolic surgery. So what are the guesses here? Educated guesses. So we have A, no one. And then B, we have 50% for B. C, we have 9%, 18, and 23. So it's really a split probably between B and E, if I would say a split, but really people like probably B more. So So perfect. So that's really the thing. So I wanted to pull, so I was trying to trick you guys, but I wasn't able, at least I was able to trick 50% out of you. So so here's the thing. I want to break this up with the different choices that there are there. So the first, A said that BMI is not a predictor for diabetes remission. And for those, I would have loved if this was more of an interactive like session. But for those of you, really, BMI is really not a predictor for diabetes remission. So at least that part of the answer was right. But the part that was not right is that patients with controlled hemoglobin A1C would not have an added metabolic benefit from surgery. So it seems like this patient probably had NAFLD on top of his type 2 diabetes and had dyslipidemia as well. So metabolically, the patient was not very, very healthy. I did not add his waist circumference, but we would probably think that he probably has metabolic syndrome on top of that, and a bigger waist circumference, given that his BMI is on the higher side and above 40. So B was actually just copy pasted from ADA verbatim. So this is exactly what the ADA says. The ADA says that if you have someone with a BMI of 40 and above, the trials have shown, and I'll show you the trials, the benefits of undergoing bariatric surgery. When you look at C, the patient has good diabetes control with a good regimen, is on liraglutide, which will help with his blood glucose control and his weight. Yes, even if this patient was on semaglutide, which probably would have had a better control on his weight, really still metabolic surgery would be beneficial for them, because we do have the data that shows so far that metabolic surgery is probably the most effective mode of treatment for type 2 diabetes that we have so far. D, Stampede trials shows relapse of diabetes at 5 years with sleeve gastrectomy. That is true. Mangroni shows 5 years with Roux-en-Y. That is also true. And with BPD, very rarely, but there, it is. Mangroni was actually looking at complete remission. Stampede was looking at patients who had type 2 diabetes and compared them to best medical treatment. Their target was hemoglobin A1C of less than 6.5%, regardless of being on meds or not. So they were allowed to add anti-diabetes meds to the patients. It was more of looks like a real world evidence. But again, therefore, although metabolic surgery is an option for this patient, he may not benefit from the procedure on the long term. That is the wrong thing. Regardless of relapse of diabetes, patients still have weight loss independent effects of bariatric surgery when they have type 2 diabetes. The last one, both duration of diabetes and insulin use are predictors for remission of type 2 diabetes. That is completely correct. Since the patient has diabetes more than 5 years and is on insulin, he may not benefit. That was the part that was wrong, that he may not benefit, he would still benefit. And I'm going just to show you data from the Stampede here, where you can see here the comparison. And I've actually, this is a built slide where I put in all the Stampede trials, all the 5 years together. And you can see here that this is best medical treatment. So people were actually allowed to add as many medications as they wanted, as compared to sleeve gastrectomy and Roux-en-Y gastric bypass. And you can see that the hemoglobin A1C level got the best results at about 1 year, and the results of both sleeve gastrectomy and Roux-en-Y gastric bypass were very, very similar. But as the years went by, that those levels were not as good as year one, but still those patients did way better than intensive medical treatment, where you can see that intensive medical treatment just kept getting worse as years went by. When I was talking about the metabolic surgery, it's really, with type 2 diabetes, it's really important to note that with basically with the Stampede trial, they were able to pool a number of patients with type 2 diabetes who underwent Roux-en-Y gastric bypass and sleeve gastrectomy from centers in the United States and centers basically in Spain. And they created a model and looked at, they matched them and created a model to see predictors of remission of type 2 diabetes. And what they saw is that if you look, they created this score where you had mild, moderate, or severe diabetes based on this score. and they just put in the predictors there, and they went, if you had, if you were on diet, the number of diabetes medications that you were on prior to surgery was a predictor of remission. Pre-op insulin use was another predictor of remission. Pre-op duration of diabetes, if it was more or less than 5 years, that was another predictor. And pre-op glycemic control, which is less than 7%. Our patient had a hemoglobin A1C of 6.55, if I remember. And then they looked at that, and based on that, they would recommend the type of surgery. So if you had mild diabetes based on this score, then a Roux-en-Y gastric bypass would be suggested, because both procedures, none of the procedures saw superiority over the other. But if you had moderate, actually Roux-en-Y gastric bypass showed a more superior, was a more superior surgery than sleeve gastrectomy. And if it was severe, then really a sleeve gastrectomy was suggested, because both procedures really didn't do much for the patient's diabetes. You can find the calculator online. You can get it from the App Store if you want. It's called VeriCalc, and it actually even predicts that. I'm not going to go into that today. It actually even predicts relapse of diabetes. So you can actually tell your patients if they're going to go into remission, and if so, what is the percentage of their relapse and when is it going to happen, if it's going to happen. So it's really important to manage patients' expectations before sending them for surgery. So these are the things that I just mentioned, and it was really, really important to mention that BMI was not a predictor of remission of type 2 diabetes, but what was actually a predictor is waist circumference. So current recommendation now from the DSS-2 was metabolic surgery should be recommended to treat type 2 diabetes in patients with BMI more than 40, and those with class 2 obesity 35 to 40 to almost 39.9, when hyperglycemia is inadequately controlled, and it should be considered in patients with type 2 diabetes and a BMI of 30 to 34.9. And you have to just reduce that by 2.5 for Asian patients. This is ADA, DSS-2, ACE-MBS, and if so, actually recommend surgery for patients with diabetes at 30 to 34.9. And actually, so they have smaller cutoffs for those with diabetes. This was published 2022, if I'm not mistaken, maybe 2022, I believe. So the ASMBS guidelines. Why is this very important? Why is metabolic surgery? Why are we saying it's still important, given that the patient was in a great regimen? Hemoglobin A1C was 6.5. What is the benefit? So if you look at here, all the randomized control trials, and you look at microvascular complications, and then you look at the other trials favoring surgical versus favoring medical, or the observational trials, you'll find that looking at a pool of about 18,000 patients, you'll find that surgery had reduced event by 74%. Microvascular complications, which is there is no medication that you're able to give that will make that big of a difference in patients with type 2 diabetes. Again, if you look at patients with albuminuria, patients with type 2 diabetes and albuminuria, this was a famous study done by Roberta Cohen. You'll find that compared to patients who have best medical treatment at 12 months or at 1 year and 2 years, patients who did Roux-en-Y gastric bypass had improvements in their albuminuria as compared to those patients who did not. It is very important to note, though, that this study, although published in 2020, patients' SGLT2 was not part of quote unquote best medical treatment. So it'll be very interesting to see another study. This is a mom's trial, to see another trial looking at those patients who have type 2 diabetes who actually are on SGLT2 inhibitors, and see if we are going to see the same impressive results with bariatric surgery versus best medical treatment. If you look at macrovascular complications, cerebrovascular, if you look at these Kaplan-Meier curves, you'll find that metabolic surgery, wins with matched controls. A decrease, 52% decrease in cerebrovascular events. Coronary artery disease, there's a 45% decrease with patients who had metabolic surgery as compared to the matched non-surgical patients. You'll also find with all macrovascular events decrease 48% in those patients who have undergone surgery as opposed to those who's never undergone surgery. All-cause mortality, and again, we always tell you, let the mortality benefit drive your decision. A whopping 70%, there's nothing like it in entire medicine where you have a 70% decrease in mortality just by a procedure. So that is why bariatric surgery is still the best and most effective treatment for patients with type 2 diabetes who have obesity. So next, this is a 32-year-old female with class 1 obesity, BMI of 33. She's in your clinics because she wants to treat her obesity. She does not have any complications from her obesity, and she has no contraindication of the use of any anti-obesity medications. You discuss with her all the options and possible side effects. She tells you she wants the most effective thing that you have. I actually had to change this question yesterday, trick question. On average, in randomized controlled trials, which is the FDA-approved option with the most efficacy? Is it semaglutide 2.4, fentramin, liraglutide 3 milligrams, fentramin to pyramid combination, or bupropion naltrexone combination? So semaglutide 2.4, 65%, 24% were 3 milligrams, liraglutide, fentramin to pyramid, bupropion, naltrexone didn't get any votes. Okay, great. So I had added to this tirzepatide yesterday, the day before yesterday, since tirzepatide was not FDA approved, but it got FDA approved, and I had to remove it because it actually is the most effective form of treatment that we have. Now it's FDA approved. If you would have chosen it 2 days ago, it would have been right. Semaglutide 2.4 is the most effective, and I'm just going to show you the data. So this is all the medications that I had included, here. And I have also added the tirzepatide because I know you guys probably will be asked about it now, probably that it is approved. So here's the fentramin to pyramid, the brand name Kissimmee. This is the EQUIP, SEQUEL, and CONQUER trials. And then you've got the naltrexone, bupropion data, which are the CORE 1, CORE BMOD, and CORE 2, and CORE diabetes trials. And then you've got the liraglutide 3 milligram trials, the iStrip and the Biciner. And then you've got the semaglutide 2.4 trials, or the STEP trials. And then you have the surmounts for the tirzepatide 50 milligram. And here you can see the line of the 5% clinically significant weight loss, and you can see which drugs actually cross this line and which drugs don't. And here in gray, you'll find the placebo effect or the diet effect. In order to see how the drug is effective, you have to remove that placebo effect. So for instance, it's really, if you look at the far left here, you can see the CONQUER 9.3 plus 1.6. So it's really in the trials, it really reports about a 12% total body weight loss, but the truth is placebo effect is only 9.3%. So this is important for you to know. You see the naltrexone, bupropion data is really not that good. Liraglutide is not a good medication for those who chose liraglutide 3 milligram. It's really not a very effective weight loss medicine, on average 6 to 8% only. Semaglutide, very effective, 14.9% placebo subtracted. Tirzepatide about 20% placebo subtracted. Surmount 3 is showing about up to 25% of a total body weight loss on a Surmount 3. So this is these are the drugs. The STEP trials, semaglutide, there's the weight management trial, and then weight management with type 2 diabetes. Always just remember that if you have, that's the step 2. The other ones, the sustained and the step 3 and step 4 are, it's just showing you that across the board, semaglutide is going to cause about on average about 15% total body weight loss. With type 2 diabetes, you're going to get less weight loss because no matter what intervention you give, even metabolic surgery, when you have diabetes, you lose less weight. And this is just showing the categorical body weight losses. So how many people actually lost 5% of weight and more? How many people lost 10% and more? And how many people lost more than 15% and more and 20 and more? So you can see here with the different drugs, semaglutide 2.4, liraglutide, and placebo, you will see that about 87% of patients who are on semaglutide 2.4 will lose a minimum of 5% of total body weight loss. about 70% will lose a minimum of 10%. Half of the patient will lose 15%, and then about 1/3 of the patients would lose 20% or more with semaglutide 2.4. Important of note, we do not have semaglutide 2.4 milligram brand name Wegovy still here in Saudi Arabia, but it is, I think they already have it in the Emirates, and it is FDA. It's been FDA approved for now almost 3 years, 2 to 3 years. It just hasn't gotten here as of yet. So the next question. 35-year-old female with class 3 obesity, BMI is 40.5. She's in your office. She's depressed. She's crying about her weight. You state that she has tried everything, but nothing works. Her primary care physician had tried phentermine, liraglutide 3 milligrams, and leucovorin in the past. Leucovorin is an older drug that has been pulled off the market. And she had failed all 3 medication and was not able to lose 5% of her weight with any of them. And you see these, and it's never the fault of the patient. It's always the fault of the biology. It's just a non-responder, which is okay. After full evaluation, you found out that in addition to her class 3 obesity, she has obstructive sleep apnea and diabetes with a hemoglobin A1C of 8.5%. You discussed with her metabolic surgery as a possible treatment method. The patient is happy about pursuing this option since her sister had had metabolic surgery in the past 3 years ago and has lost 25% of total body weight loss. The patient is fearful of her chances, though, since she has failed all other modalities in the past. And she tells you what predicts my success. Why would I succeed? I failed everything else. Is it her? So let's see. So is it her that early behavioral adherence to lifestyle after metabolic surgery will predict greater weight loss initially and ultimately greater weight loss on the long run? So those patients who actually stick to their lifestyle in the beginning, are they going to lose more weight? Or does the patient's poor response to pharmacotherapy, especially the GLP-1 agonist, predicts poorer response to surgery, since this is one of the known mechanisms of surgery? Or is the most important factor at predicting the patient's response would be her diabetes, because she has diabetes, and we did say that people with diabetes really do not respond to bariatric surgery as well as people without diabetes? Or is it the most important factor in predicting success would be the level of blood glucose control prior to her surgery? Or is the most important factor in predicting her success that her sister succeeded in bariatric surgery? So let's see what you guys have answered. So early behavioral adherence to lifestyle after metabolic surgery will predict greater weight loss initially and ultimately greater weight loss on the long run. Okay, so this talks about my failure to actually explain to you guys that it's really biology. It has nothing to do with behavior. So behavioral adherence has no effect at all on what happens with bariatric surgery. So this is the only predictor is actually her sister's response. So first degree relative is the predictor for success for surgery. So when someone comes to you and tells you that I've had a sister or my mother had bariatric surgery and they didn't lose weight, then you tell them most likely you probably won't respond, regardless of what they do and regardless what their behavior is. So here is the data. So bariatric response to surgery is genetically determined, and this was a very elegant study done in our lab at Harvard at Mass General. And what we had patients who were first degree relatives, and we had patients who are unrelated and cohabitating patients. So what we saw was cohabitating means a husband and wife who decided to have surgery at the same time. So they were buying the same food, they were doing the same things, so the behavior was the same. And then unrelated, where patients were completely unrelated, just 2 people, and then we compared them. And then we had first degree relatives, and what you can see is that really cohabitating and unrelated is exactly the same. And really first degree relatives were the only ones who were actually able to lose the same weight. And this is very old data also from, the twin studies in the past by Dr. Stunkard in the past, where they looked at twins who were raised in 2 different households. And when they looked at the levels of obesity in those twins, it was the same level of response to whatever intervention you do is basically the same. So genetic factors account for 70% of variability between first-degree relatives. And when they looked at that, they actually looked at a few genes, and this was in suboptimal and the differences in weight loss. And they found, and this again was done in our same lab at Mass General. What we looked at was, some different allele, the GG allele, AG and AA allele, and if you held the GG allele, you were most likely to lose more weight, 38.7% of total body weight loss after Roux-en-Y gastric bypass, as opposed to those individuals who had an AG allele, 33.5%, as opposed to those patients who didn't have G at all, and it was AA, 28.8%. There was a 10% difference in total body weight loss just by the difference in genetics. Again, suboptimal weight loss is things that are predicted are higher initial BMI, limited physical activity, diabetes, lower education levels, fewer post-operative appointments. But again, this does not explain the whole story, and only composite all of these in combination only account for 40% of the variability that we see, and 70% of the response is really genetic. So the next question is, you have received a consultation from hepatology regarding a 45-year-old female with obesity class 2. She has NASH and a fibrosis stage 3 on liver biopsy. The GI team are asking you about expected benefit of treatment if the patient's obesity. Best answer would be semaglutide has been tested and showed really a significant benefit in these patients. And I'm sure you're getting a lot of referrals for semaglutide for NASH. B, the obesity-related complication NASH was advanced, and weight loss will have an impact on quality of life only, but still not, because this is not NAFLD. C, that bariatric surgery will lower the risk of progression to F4 cirrhosis, hepatocellular cancer, and liver-related mortality by 88%. And D, bioclitazone is the only proven intervention to improve her NASH. And E, there's a higher chance she'll progress to liver transplant after the surgery, as her liver will not tolerate surgery and any improvements in her weight. So what do you think the answer is here? So it's semaglutide versus, I would say, bariatric surgery. Okay. So it's very interesting. So you guys know that semaglutide. So it's really bariatric surgery that has been proven. Again, another win for bariatric surgery. This is from the Splendor trials, and this looked at patients with NASH, and what you can see with NASH and just the story of semaglutide and quick is that these patients. So this is a Splendor trial looking at non-surgical controls compared to bariatric surgery with liver. You can see that the incidence of major adverse effects and outcomes was less in bariatric surgery as compared to the non-surgical controls. It was about 88% difference. But what is very, very important, and this trial was published in 2021, so I think it should show up in your boards right now. Is the interesting story about semaglutide. Semaglutide had 2 studies published in the New England Journal of Medicine. If I'm not mistaken, I think both were there. The first trial was looking at semaglutide on a daily basis for those individuals in NASH, and the second one was looking at 2.4 on a weekly basis. None of them got the cut for FDA approval. The reason being is that there was no remission in the fibrosis, and that's the cutoff at the FDA. You have to have improvement in fibrosis for individuals with NASH, as opposed to bariatric surgery, where at 5 years after surgery, when biopsies are taken, you will find that the fibrosis had actually went away. So the only available effective treatment so far for NASH is actually bariatric surgery. So next, 50-year-old female with obesity class 1. She was started on phentermine and topiramate 9 months before she saw you, with a good response, about 11% total body weight loss. Great response. She had a significant reduction in her vision recently, and she had a history of renal stones before 3 months. What is the best intervention to do for now? Reassurance and continue the medication as she has significant weight loss. B, switch her to another anti-obesity medication. C, refer her to a neurologist for further workup for her forgetfulness. And D, request an MRI. Switch her to another anti-obesity medication, and someone wants to request an MRI. Okay. So this is, I tried to bunch off all the adverse effects of the medication in one because, I was told you get asked about adverse effects, a lot. So I'm just going to go through these just before. So she has reduction in her visions recently. And what happens with topiramate is acute angle closure glaucoma. And that's a contraindication. So it's really important to have that in mind when patients are on drugs that have topiramate, even when you use topiramate off-label for obesity, which we do a lot, right? And also the other adverse effect is renal stones. Again, I tried to sneak something in the MCQs, which was refer her to a neurologist for further, not for forgetfulness, because it also has, it's not really forgetfulness, it's very specific word finding difficulty with patients who undergo a topiramate. But the answer is really switch her to another medication because she's developing adverse effects from the topiramate section of the drug, not the fentanyl section. Okay, so it's been associated again with acute myopia, secondary angle closure glaucoma in adults and children. We discontinued it in this patient. When they have the iridotomy, they usually do it both eyes. So I've been asked before, when they had it, what if they develop in the other eye? It's usually when you have one and surgery is done, it's usually done prophylactically in the other eye. You can restart the medication. It's fine. Renal stones happen. So topiramate, because it's a carbonic anhydrase inhibitor, it may cause renal stones to occur in patients who take it. So it's really important to talk to your patients about that. So next, you were consulted regarding a male patient. He has class 2 obesity. He has a BMI of 37. And the patient has been smoking one pack per day since 2019. He was also diagnosed with depression, for which he is on citalopram. And the patient's history is significant also for recurrent renal stone and pancreatitis without an identified cause. Which of the following anti-obesity agents is the best choice for his condition? Is it bupropion, naltrexone, GLP receptor agonist, liraglutide, semaglutide? Is it topiramate, phentermine? Is it to offer a lifestyle, as the patient has contraindication for really all the medications that we have? So bupropion and naltrexone got a vote of 43%, GLP receptor agonist of 22%, topiramate, phentermine 8%, offer lifestyles as the patient's contraindicated for RADI. So let me, if you're going to learn anything from this, we just talked about lifestyle intervention is not a treatment for obesity. Lifestyle intervention is an important thing for health, for any disease, for diabetes, for hypertension, for all chronic diseases, but it is not a standalone treatment. So I wouldn't consider that as the answer. Liraglutide, semaglutide with a history of pancreatitis that did not have a cause. And I specifically wrote here, it does not have an identified cause because I didn't want it to be very tricky. I could have said biliary pancreatitis. If the cause was biliary pancreatitis, then a GLP-1 receptor agonist would not be contraindicated. Because it's not a defect to the pancreas, it's a stone that caused the problem. He has depression, so bupropion, naltrexone, and is a smoker. I tried to put those two. Bupropion, naltrexone is a very good choice for this patient, again, because the bupropion, naltrexone is going to treat his depression as well as make him stop smoking and as well as make him lose weight. So it's a threefer. So the next question would be Mrs. Smith. She is a 35-year-old woman. She is 4 years post-laparoscopic Roux-en-Y gastric bypass with 25% total body weight loss. She presented to your clinic with a complaint of low blood sugars that started 6 months ago. Mrs. Smith says that 1 to 2 hours after taking her meals, she gets episode of sweating, palpitations, and dizziness. These episodes occur about 4 times per week. She does not have a history of diabetes before her surgery, but she is worried now that she is developing diabetes. She tells you that she measures her blood sugars when these episodes occur. She reports reading ranging from 80 to 50 milligrams per deciliter. Mixed meal testing reveals hyperinsulinemic hypoglycemia. Which of the following statements is true? A, when compared to non-surgical controls, all individuals who have undergone Roux-en-Y gastric bypass will have hyperinsulinemia. B, when compared to non-surgical controls, only individuals who have undergone Roux-en-Y gastric bypass and have postprandial hypoglycemia will have hyperinsulinemia. C, dumping syndrome causes hypoglycemia in individuals who have undergone Roux-en-Y gastric bypass. And D, postprandial hypoglycemia is a complication of Roux-en-Y gastric bypass, but not really of laparoscopic sleeve gastrectomy. Okay, this breaks my heart. Okay, so 11% says when compared to non-surgical controls, all individuals will have Roux-en-Y will have hyperinsulinemia. 15% for the next choice. 47% with dumping syndrome causes hypoglycemia in individuals who have dumping syndrome does not cause hypoglycemia. Dumping syndrome basically causes symptoms of shivering, and so it's a fluid shift. So post-bariatric hypoglycemia is not synonymous with dumping syndrome, and you guys should know this now. And I've seen this in a lot of endocrinologists, I'm one of them, but I saw this on a lot who do not do obesity medicine, so they don't do a lot of surgical patients, is that they think that hyperinsulinemia is an abnormality in Roux-en-Y gastric bypass. And here is the data. Really, when compared to non-surgical control, all individuals who have undergone Roux-en-Y gastric bypass will have hyperinsulinemia. So when you do the mixed meal testing for these patients, you will find that they'll have hyperinsulinemia. So how do we differentiate? And this is what happens in patients when you put them on CGMs. You'll find that after the meals, they get these hypoglycemic events, and this is what differentiate the post-bariatric hypoglycemia from the dumping syndrome, where those will just have the symptoms, but in reality, their blood sugars will be normal. So here is just a schematic, and I think this was actually published in the JCEM. You'll find it. This was by Marianne Patty, and what you can see here. The non-surgical control here are in gray, and I want you to look at them. And then you'll look at the dark black here is the hypoglycemia, Roux-en-Y gastric bypass, and then the and then the asymptomatic Roux-en-Y gastric bypass. So those who do not have the hypoglycemia are in the dotted line. And what I want you to see here is their insulin levels, because that's what got you. So what you can see here is that in the non-surgical controls, what's happening is that after food, they're having these surges in insulin that are following surges in GLP-1 in box E here. So they're having these little small surges in GLP-1, not as prominent, but they're having a little blip there. But the non-surgical the asymptomatic patients as well do have a surge in both GLP-1 and a surge in insulin. But those with hypoglycemia have a greater surge. So this is the thing. So when you find someone with hyperinsulinemia, that necessarily in a mixed meal test does not mean that they have hypoglycemia. You will find almost all patients with Roux-en-Y gastric bypass will have hyperinsulinemia just by default, because they've had the surgery that will increase their GLP-1 response and accordingly will increase their insulin response. But there is this small, minute amount of patients that are going to develop hypoglycemia as a result of this. Available option for management of post-bariatric surgery hypoglycemia is nutritional management, where more than 90% of individuals are going to, and it's really educating them about how to eat. Alpha glucosidase inhibitors such as acarbose, CGMs, diazoxide, octreotide. I use pasireotide sometimes, and gastrostomy tube, just changing where the food is going and bypassing that area where you have that extra GLP-1 so you don't have that extra insulin. And this is a schematic that you can find in the same paper by Marianne Patty, again, published in the JCEM in 2018. It's a nice, cute review that you can look at. 10, you have been discussing weight loss with a patient who had obesity for several years. At today's visit, he mentions that each time he goes on a diet, he feels hungry, and that's why he can never stick to a diet. Explain to him that energy restriction increases hunger hormone ghrelin, and that is why he's feeling hungry all the time. He then asked about other diets like the Atkins diet, which is a high protein diet, by the way, in keto diet, and state that his friends following those diets do not complain of hunger as much. How do you best explain the lack of hunger to your patients with keto diets and Atkins diets? Is it that the Atkins diet and keto diet are high protein, high fat diets and therefore are more dense and filling? Is it because of the composition of the Atkins diet and keto diet, there's less insulin surge after meals and therefore not as much hunger? Is it because ghrelin is suppressed longer by proteins than by lipids or carbs? Is it because ghrelin is suppressed longer by lipids than by proteins or carbs? Or is it because of the protein high fat composition of the Atkins and keto diets? So gastric emptying will become slower and therefore individuals feel fuller longer. Okay, interesting. Again, a split. I love questions that splits you guys, which is very interesting because I actually rewrote E and A with probably the same. Really, ghrelin is suppressed longer by proteins than by lipids and carbs. You need to think as an endocrinologist. There's a science behind everything. It's not mechanical. It's not because of slow gastric emptying. It's not because of density and filling. It's because of ghrelin is suppressed by proteins. And this is why we give people protein shakes when you go to energy restrictive diets, or so you go to these places, commercial places, they give a lot of people protein shakes and they'll tell them that's going to suppress your hunger. They don't understand why. It's because ghrelin is suppressed longer by ghrelin. And that's why people on a keto diet really don't get hungry. Carnivores, once you eat a steak, you don't get as hungry after it as when you eat a carb. Okay. Ms. Meha is at your clinic today, complaining of difficulty in losing weight. She's 82 kilograms today with a BMI of 36. She said that she has was at her usual weight of 75 for several years, but over the past 1 year, she has been gaining weight steadily. When asked about her weight history, she endorses no change in her microenvironment, and other than, an allergy pill that she takes, no new changes in her medications. You suspect her antihistamine to be the contributor to her recent weight gain. Which of the following antihistamines is associated with the least amount of weight gain on average? Is it criheptidin? Is it doxepin? Is it loratadine? Is it fexofenadine? Is it cetirizine? Okay, good. So really, that is so true. So the less sedating the drug, just take it as a thing. The less sedating the drug, the less basically weight gain it causes, because of the longer acting ones, the ones that have more blood-brain barrier are going to cause the more weight gain. And when I was talking about microenvironmental factors, I want you to always think about these, not really lifestyle, but the weight gain promoting medication, the nutrient signaling, or the diet the patient is on, muscle activation, the sleep, circadian rhythm, and chronic stress. All of these will interact with your genetic age, sex, and development, and cause changes in energy balance. When you look at medication that promote weight gain, think about them in 3 categories: CNS drugs, endocrine agents, and miscellaneous. CNS drugs, the biggest offenders are atypical antipsychotics, antiepileptics, lithium, all the antidepressants really, other than Wellbutrin or bupropion. Endocrine agents are insulins, are sulfonylureas, or steroids, obviously. And then miscellaneous, things that you don't think about: beta blockers, antihistamines, sleep aids, and antiretrovirals. And those are the weight promoting drugs that usually have. Okay. Next question. A 35-year-old woman comes to your clinic with a complaint of 8 kilograms of weight gain after her psychiatrist started her on quetiapine 18 months ago. She is desperate to lose the weight, but despite everything she had tried, she is not only unable to lose the weight, but also is unable to stop the steady weight gain. So it's not only weight loss, it's weight gain that's happening, a continuous weight gain. She's asking you to help her. Which of the following drugs has been shown to mitigate weight gain associated with the use of antipsychotics? Is it topiramate phentermine, bupropion naltrexone, metformin, or empagliflozin? Topiramate phentermine, bupropion naltrexone, metformin. Okay, interesting. So this actually has been studied in randomized control trials, and you guys should know this. So metformin is the only drug that has been shown in randomized control trials to decrease weight gain and mitigate weight gain and actually causes weight loss. And you can see here, Okay, and you can see here, this is the trial, and you can see lifestyle plus metformin actually in patients on risperidone, where they lost about 7.28% of their total body weight loss when put on metformin, or from between that and 5%, as opposed to patients that only underwent a lifestyle intervention where they didn't lose any significant weight loss. Patients on placebo actually gained at least 5% of their weight. So metformin has been very, very well studied with atypical antipsychotic. She's on quetiapine, which is a Seroquel, which is an atypical antipsychotic. So she probably qualifies for the start of metformin. And we know the same thing happens with type 2 diabetes, right? Those patients on the atypical antipsychotics are going to be at risk of developing type 2 diabetes. So metformin is really a win-win in these patients. Okay, next question. 43-year-old male, known case of obesity, a BMI of 39. It's complicated by hypertension since 2015. The patient is planning to do a Roux-en-Y gastric bypass after 3 months. He is on losartan 100 and amlodipine 10. His blood pressure reading is 150/95. He's willing to know the expected benefit of bariatric surgery on his hypertension and the chances of remission. What would be the best answer to his question? Effective weight loss surgery on hypertension is really unpredictable. There's a low chance he will be off of the medication. There's a 30 to 40% chance that his hypertension will resolve over 3 years. And there's a 15% chance of reduction of antihypertensive medications after 3 years. So it's good. There's a 30 to 40. So people have read the Gateway trials. So the Gateway trials were first published, so 30 to 40% chance. So they were first published back in 2017, and then the 3-year follow-up was published, I think, beginning of 21 or end of 20. And you can see here that the Gateway was comparing patients who underwent gastric bypass to optimal medical therapy. So it was really the stampede, but for hypertension. And they looked at the different medications, the number of medications at baseline and at 2 months. And you can see the differences. Obviously, the differences in hypertension are not as robust as we see in type 2 diabetes, but we can see that as compared to optimal medical therapy, bariatric surgery does the best, and people actually do have a 40% chance of remission at 3 years in the Gateway trial, as opposed to not if they've undergone a Roux-en-Y gastric bypass. So at 3 years, as I said, 73% achieved the primary outcome, only 11% in the medical therapy group, 35% of patients from Roux-en-Y group and 2% from the medical therapy achieved the secondary outcome of blood pressure control without medication. So about 35% were able on surgery to go on to be completely off medication in the Gateway. And it was actually 2020. The 3-year follow-up. So the next question would be, which of the following is the most common set of finding for an otherwise healthy male with obesity? Normal, I apologize for the not using first-person language. Normal testosterone, high sex hormone binding globulin, low free testosterone, or normal total testosterone, low SHBG, low free testosterone, or low total testosterone, high SHBG, low free testosterone, or low total testosterone, low SHBG, and normal free testosterone. What would you find? Full disclosure, I do not like these kind of questions, but I just wanted a mix from long stem versus one-liners. And I kept them at the end because I knew I was going to run out of time. Great. So most of you know this, and this is basic endocrinology. What happens with obesity is that sex hormone binding globulin goes down, and therefore we will find low total testosterone on labs. But when we actually check our patients' free testosterone, you'll find that they have normal free testosterone. Last question, I believe. 55-year-old postmenopausal woman with a BMI of 54, history of insulin-dependent type 2 diabetes, has been evaluated by a bariatric surgeon and scheduled for a gastric bypass. Which of the following statements about her preoperative work is false? A, she should lose 10% of her body weight before surgery, as is associated with better weight loss outcomes after surgery. B, if she needs a stress test, a dobutamine stress echo would be the most appropriate given her BMI. C, tobacco use should be stopped 6 weeks before surgery. hormone replacement therapy should be discontinued to reduce the risk of postoperative venous thromboembolic diseases, and a prophylactic vena cava filter may present a greater risk than benefit in patients with a history of venous thromboembolic diseases. Remember, we're looking for the false one. Perfect. So 46% of you understand that weight loss before surgery does not carry any benefit. This has been studied very, very well. And really, the ASMBS, or the American Association for Bariatric Society for Bariatric and Metabolic Surgery, and the International Federation for Surgery for Obesity recommend against weight loss before surgery in patients with obesity. The reason being is that studies have showed that you actually do delay a life-saving surgery for no benefit at all, because randomized controlled trials have shown that there is really no benefit in the 30-day mortality or others. So I think this is my last question, and I'm going to stop here. I hope I finished on time and didn't go overboard, because I tend to do that.
Thank you so much, Dr. Nesreen, for this comprehensive overview covering most of the burning topics in obesity as well as the basic topics. Really excellent coverage. So in the next 15 minutes, we're going to go over the questions. So let me see what we have here. So to start with, there's a question. Is BMI changed to 35 is to repair? So the question, it means that if you have a BMI of 35, would that be an indication for surgery? And I think you covered that, but just a quick answer to that.
Do you mean a BMI of 35 for patients with type 2 diabetes, or in general?
There is no specification. Yeah, you can.
So let me give you both the answers. So a BMI of 35 with no complications, as based on the International Federation for Surgery of Obesity and the American Association for Surgery for Metabolic Surgery, is an indication for surgery without any complications. The ADA, though, for diabetes, it recommends a BMI of 35 with diabetes for a recommendation for surgery. So it depends what you're looking at. The surgical the committee has already actually lowered its threshold for obesity because of the data that shows the weight loss independent benefits of surgery, especially that in the Stampede trials as well. And that's where the recommendation for the 30 and above came up. The inclusion criteria was patients starting with a BMI of 27. So even with pre-obesity.
Very good. So it's very important to know if you're looking at diabetic versus non-diabetic. Now, another question is here, if you can mention briefly about the different types of metabolic surgery and which one is extremely better with lower chances of weight regain.
So that is a very, very good question. So when you look at the different types, so we have more than 7 types of surgery, and I'm sure before I just said that they're probably now 8 or 9, because surgeons keep coming up with very, very creative ways of changing the anatomy to try to get the most hormone effect. If you look at regain, so to speak, we no longer do extreme surgery. So you look at something like biliopancreatic diversion, and patients who undergo that really don't regain weight as much as sleeve gastrectomies. But when you look at benefits versus harm, you'll find that those patients end up with more complications, more nutritional deficiencies. And so it's really what we tell our patients is everybody regains some weight. So that's the normal. The surgeons may not like to say that, but we do know that as a fact that everybody has to regain the weight, to regain some weight. When does the weight regain becomes pathological? That's where there's a difference. We have a very clear definition for suboptimal weight loss or patients who do not respond to surgery, but we do not have a very clear definition for weight regain or weight recurrence, what's being called now as weight recurrence. But we do look at the patient's initial BMI or initial weight. We do look at the nadir, and we look at how far from the nadir they are. Some people are as aggressive as 3% away from the nadir. They start worrying. Depending on the starting BMI, I would give patients about 5 to 10% from nadir before we start worrying about recurrent weight gain. But if you're going to compare Roux-en-Y gastric bypass versus sleeve, which is the commonest surgeries that are being done, you have more weight regain with sleeve as compared to Roux-en-Y gastric bypass.
And this brings us to the next question. So with the weight regain, what is the rule of using GLP-1 agonist post-bariatric surgery for the weight regain, as well as to treat hypoglycemia post-bariatric surgery?
So this is a great question. So so we have a lot of we have a lot of observational data, right? Or a lot of prospective trials that have looked at different drugs that are being used post-bariatric surgery. The largest one was actually the one that we did because it was between our center and Cornell. It was about 319 patients, and we used more than 15 medications on label and off label. We used GLP-1 receptor agonists in that trial, and our patients on average lost 5% or more of their weight on different medications. If you look at randomized control trials, I will only point out to the Gravitas trial. The Gravitas, although that was done by Alex Miras a couple of years ago, if I remember correctly, the only issue with the Gravitas is that it looked at those patients who had type 2 diabetes, and we do know that patients with type 2 diabetes lose less weight. So that probably was not a perfect trial to look at with weight loss, because we knew they were going to lose less weight. Secondly, it was not powered to catch weight loss. It was powered for diabetes and how the diabetes got better. There's the Berry Optimized that's going to be published, another randomized control trials, and there is the Berry Step as well, is going to be published. Both these trials, again, looked at suboptimal weight loss, not really weight regain, but regardless of the fact, that's a great choice. Regarding GLP-1 receptor agonists in post-bariatric surgery hypoglycemia, we do use them. We use them all the time, and if you have someone with weight regain as well, it's a twofer. It's great. Try it with your patients. If it's working, then great. If it's not, then try something else. But they do work, and we really don't understand exactly why they work.
And I think there was a recent trial they looked at starting and considering GLP-1 as early as possible, because you expect the weight regain like 2 years after the bariatric surgery. And there was one study they looked at considering the GLP-1 earlier, probably on. I can't remember exact study.
So in general, so this data was also extrapolated from our data set, because when we published our paper, what we saw is that if you started an intervention medication, anti-obesity medication, at a weight plateau, you ended up losing as much weight as if you started it at weight regain. So there was a whole thing about talking about starting medication earlier rather than later, because you probably will get the most benefit rather than waiting for weight regain and then starting medications.
Yeah. Another question is here about the caloric restriction. So what is the best way to lose weight if a calorie restriction is associated with increased weight in the long run for class 1 obesity?
So perfect. So the best way to lose weight is through treatment. So let us talk about, so people tend to think that it's like a pyramid where you start with lifestyle intervention, and then you move on to pharmacotherapy, and then endoscopic therapy, and then probably bariatric surgery, and then post-surgical combination therapy. And what we say, it's really not that way. It's a Venn diagram rather than you start. So when someone comes in with class 1 obesity and you get the weight history, and so if that person is really eating unhealthy, so then by all means send them to the nutritionist and tell them to educate them about what healthy eating is. But that doesn't mean that you withhold medication from those patients. It's like someone who comes into your office with a hemoglobin A1C of 6.8%. Do you give them the metformin, or do you tell them, okay, you need to go now and try a diet first, because we know that if you cut your carbs, your diabetes will get better. And then if that doesn't work, then when you come back, and I'm going to start the medication. We don't do that. We shouldn't be doing it with obesity.
Mm-hmm. Okay, interesting. And there is a question about the antipsychotics and weight gain. So there is one question about, is the antidepressant that causes weight gain, or is it the improvement of depression symptoms, as some psychiatrists claim? I think the question, they mean that the weight loss that you see when you do any sort of intervention? Is it the elevation of the depressive symptoms that improves the weight, or the intervention? I think the question is not very clear, but
so let's take it in two ways. Antipsychotics are not like antidepressants. So there is nothing that is studied with antidepressants like metformin is studied with antipsychotics. So that's why I showed the metformin specifically with antipsychotics, because even from the old days when we had olanzapine and clozapine and all of that, we knew that metformin worked, especially with type 2 diabetes, right? When we all did our fellowships, and so we knew that metformin works. When it comes to antidepressants and does the depression gets better and the people lose weight? So it's actually the other way around. So what studies have showed that if you treat obesity, depression will follow. And that's why when we have patients in our clinics, we do, for instance, PHQ-9s and do their depression scores, because once you treat obesity, then depression will get better. It's not the other way around.
Very interesting. And what about what's going on now in the field of the GLP-1 therapy? Now, let's say if someone is on antipsychotic due to any sort of psychiatric problem, and the patient comes and seeking GLP-1 therapy. Okay, and they are seeking more sort of significant weight loss. They are not happy with metformin, weight loss effect. What would be your assessment and approach, and especially with some claims recently that it might affect, we heard about the suicidal thoughts and so on?
That's a great question. So we do start, so we don't, so it is associated. There are some reports on some suicidal thoughts that are associated with a GLP-1 receptor agonist. And you would think that anything that actually crosses that blood-brain barrier, especially with GLP-1, right? Because we know there are a lot of GLP-1 receptors all over the brain and all over the body, so to speak. But we do know that there are a lot of receptors. So we do start them. You can start them off with a low dose and then have them come in after a month, see how they're doing, and then move on. Because at the very end of the day, if you were to compare, and this is the same thing with bariatric surgery, right? There is association with some bariatric surgery with suicidal ideation. But if you look at the studies, you actually have more remission of depression with the weight loss that happens with bariatric surgery than you have with suicidal ideation, as well as more remission of depression with anti-obesity medication, it being GLP-1 receptor agonist or anything else, because it hasn't been studied specifically for GLP-1 receptor agonists. So you'll find more remission than you find those suicidal ideations.
Yeah, and that's clinically what we see actually in clinical practice. Another question, interesting also, we do face it in clinical practice. What about the use of GLP-1 agonists in type 1 diabetes?
So I'm not a diabetologist. I'm an endocrinologist in general. I'm an obesity medicine person, but I can tell you that there is data, we all know about the data, that shows that GLP-1 receptor agonists are good for type 1 diabetes, regardless of the presence of obesity, right? There's good data that shows improvements in patients with type 1 diabetes. This is not, I don't think this is going to show in the boards, but in general, this is something that we do, and we give our patients with type 1 diabetes GLP-1 receptor agonists for their diabetes. Now, when it comes to obesity, we give them the GLP-1 receptor agonists for their obesity. And the old thought of patients with type 1 diabetes are, thin and, young and thin people. That's not what we're seeing in clinics, right? We are seeing more patients with obesity with type 1 diabetes, and we should treat them like anyone with obesity. So what we tell them is you may get a benefit as well for your diabetes, but it doesn't have to be that way. If you do, then great. If not, hopefully you'll get the benefit with your obesity. We'll treat your obesity and you'll be fine. So we do prescribe it, and there's really no contraindications. But as usual, patients with type 1 diabetes are excluded from the randomized control trials with obesity. Sadly, they are.
Yeah. Another quick question is, in patients with the Prader-Willi syndrome, what anti-obesity medication is the best?
So there is no best. It is with Prader-Willi, there is no anti-obesity medication, which is the best, because there is no randomized, there's no level 1 data that shows us one thing better than the other. So what we do with Prader-Willi syndrome is some individuals will send their patients for metabolic surgery, specifically for sleeve gastrectomy, because theoretically, because we know that patients with Prader-Willi syndrome, the hyperphagia is driven by hyperglycemia, and we know that sleeve gastrectomy probably affects ghrelin levels more than a room-wide gastric bypass, for instance. So we try to target that in those patients. We do not have any level 1 data that shows that that actually works. So what we do, we talk about combination therapy. So when my patients come in, we give them, all the medications that we have, and then we see what they respond to, and if they need on top of that, and we tell them you may need on top of that surgery as well. And we start gauging their response by their level of hunger and hyperphagia, because hyperphagia is just a sign of the disease. It is not the cause of the disease. Once you treat it.
Very good. And how do you see the future of treating obesity when we compare this new class of the GLP-1 combos? Now we're going to have the triple combo. Do you see that in very future that we probably have an alternative to bariatric surgery? Are we going to achieve some really positive, significant results and outcome with this class of agents?
So I think the future is really, really bright, and the drugs in the pipelines are amazing, and they're going to be very, very affordable. Give it 10 years. But the challenge, the problem that I see now is that comparison. It is not medical therapy versus bariatric surgery. The reason being is that with bariatric surgery, it is not all about weight loss, right? And I'm just going to use type 2 diabetes as an endocrinologist as a benchmark to compare, because we know that the benefits of metabolic surgery in type 2 diabetes, for instance, and in NAFLD, for instance, are weight loss independent. So does these medications have a weight loss independent effect? We still do not know. Maybe they do, but we still do not know. So we will have to follow up these patients. Let us not forget we have more than 30 years of data on room-wide gastric bypass, and that is why we know about these robust mortality benefits, cancer prevention benefits, all of these. And we know some of them are completely weight loss dependent and some of them are weight loss independent. It'll take us time to figure out things with pharmacotherapy. Secondly, what I'm very interested to see is to see how endocrinologists, primary care physician, whoever is prescribing these medications, once they start getting their hands on these powerful medications, are they going to be able to deal with adverse effects? Because one of the simplest things that you're going to see more of is you're going to see a lot of patients come back to you with biliary pancreatitis. Why? Because when you lose a lot of weight, you're going to develop biliary pancreatitis. We see this all the time with bariatric surgery. And that's why post-bariatric surgery, patients are given ursodeoxycholic acid. The surgeons are used to doing that, but the endocrinologist is not used to doing that. It's going to scare them. It's going to scare them. And it's going to be interesting to see, all the extra attacks of gout, because endocrinologists are not, and primary care physicians are not used to dealing with these huge amounts of weight loss, hair loss, all the things that those complaints that the surgeons feel very, very comfortable about, that the endocrinologists don't feel comfortable about. It always gives me a fear that the pioneers probably in those treatments are still going to be the surgeons, because they know how to deal with greater amounts of weight loss. Endocrinologists usually don't know how to do, when it's 15% and above, they don't know what they're doing. They're like, why are they losing those? What am I going to do? They were admitted with pancreatitis, but it's biliary pancreatitis. You can restart the drug. I don't want to start a GLP-1 on someone who's had pancreatitis. I get this discussion all the time with super responders. So we'll see.
We'll see, exactly. Time will tell, and you never know. It might be a paradigm shift, and endocrinologists would be experts in dealing with that. I mean, I have lots of other questions, but just for the sake of the time, it was a very great pleasure to have you, Dr. Nesreen, with us tonight. And it was a very, very comprehensive session on obesity. I would like to thank the delegates for attending the last session of the Endocrine Board Review course. Thank you very much. Thank you, Doctor.
Thank you so much. You have a great day.
You too.
Good evening, everybody. My name is Ali Al-Ma'mari, as you see, and I am working at Sultan Qaboos University Hospital and currently, just recently, I became the past president of GATE, and 3 weeks ago, I was the president. The current president is Dr. Khalid Al-Tahmani. I will give the conclusion remarks, and I would like really to thank everybody participating in this very intensive, big learning, actually, opportunity course. So our appreciation to the faculty, to the chairs, and mostly actually it comes to you, the participant, and my talk is to you. So we have actually during this course a total participant of 152. Most of them come from the Kingdom of Saudi Arabia, as we expect, always 1 and 9 resident or fellow from the Kingdom of Saudi Arabia, 24 from United Arab Emirates, and 14 other from other Gulf countries, and 5 from the countries outside the Gulf. So what we would like to say to you, all CME accredited accreditation certificate will be received within the next 3 weeks in your registered emails. So you will get the CME certificate, inshallah, within 3 weeks. And the course recorded will be shared with you in the email also within the next 10 days. So you have the opportunity actually to look at it again and again and make useful of it. Before I conclude, I would like to let you know that this course actually is meant for our fellow going to the exam, and also for a specialist who is interested in endocrine and diabetes. So our target group is this group, and we are doing our best actually to make it utilized to the maximum. Becoming a member of GATE will give you opportunity to have everything about us, and very simple and easy, and is free. So we encourage all the participants actually to become a member. It will be easy communication with them. They will know their activity, and they will know what we are doing. We have a good library actually involving so many. We finished a congress just recently with many attendees, very strong program. They will be able actually to review everything done during that congress also. And also we have webinar committee, which is working around the year, and there is many scientific sessions coming within the next year. So there is a lot of opportunity for you to become a member and become future leader of this association, which is the GATE. The GATE is the Gulf Association of Endocrinology and Diabetes. Before I conclude, and I know you spent a long time during these sessions, but it was a very good learning opportunity. I would like to say, just I enjoyed listening to Dr. Nasreen and Dr. Nasreen now, and I really happy to have all our faculty with them. Strong faculty we brought to this program. We need a feedback about whatever we during this course. So please give us feedback. My appreciation to the committee which organized this program for you, Dr. Nasser Al-Juhani. Deep appreciation to Dr. Nasser, and our appreciation to Dr. Najid Johani, Dr. Samer Isa, and Dr. Wiam Hussein. I'm talking to you because I'll be responsible as immediate past president of the 8th Gulf Endocrine Course Review Course, inshallah. And we hope to meet your colleagues or you, if you are still interested, inshallah, within the next year. Our plan to have our Congress next year will be in Abu Dhabi, United Arab Emirates, and expectation, we did not decide timing, but it will be the same maybe within October, November. It's still not decided. So we are expecting also to see you with that Congress. I would like to thank the Choice company, Mr. Rafat Husni, for organizing this program. This is not easy program, actually, to get everything in board. Everything went smooth during this course, and we are happy with that feedback coming to us. So I will not take more time. I would like to thank you all for participating, our faculty, our chairs, you, the attendees who made this course successful and will give us the feedback so to continue actually this activity. To my colleagues, Dr. Khalid Dahmani and the team, all the best wishes for a successful year coming, inshallah. And without I conclude this meeting, thank you all, and may Allah protect you. Thank you.